So a very good afternoon to everyone. Now, after the diabetes session, we have the endocrinology session. And all of us are aware that this PRENDO is a progressive reviews in endocrinology. And it has been happening annually for a few years. And for the last couple of years, we are virtual. I hope next year we will be able to meet physically. It is definitely a different scenario, but yes. So today we have a very exciting session in endocrinology. And for the first talk, we have Ectopic Cushing, which is going to be delivered by Dr. Nihal Thomas. And I would request the chairpersons to take over. The first chairperson is Dr. Zargar. I am just sharing his CV. 1 second.
I said we could do without that as well.
Dr. Zargar is a very senior professor. I think I have, senior professor and a teacher to most of us. He's from Kashmir and he's always there in any meeting that I hold. And he's one of the stalwarts in endocrinology. And yes, he does not need any introduction. I'm not able to share his slide, but I will share the slide of Dr. Ganapathy, who is...
It's okay, no problem.
No, I have Dr. Zargar's slide also. So he's at present at Center for Diabetes and Endocrine Care National Highway, Gulshan Nagar, Srinagar. And he's a member of MCI, past president of Endocrine Society and member Institute Body of All India Institute of Medical Sciences, New Delhi. He's chairman, Department of Endocrinology and director and ex-officio secretary to Government Sher-e-Kashmir Institute of Medical Sciences, Srinagar. And then we have Dr. Ganapathy, who is also professor. Is it visible?
Yes, it is.
Yes, who is the presently president-elect of Endocrine Society of India, treasurer, Karnataka Endocrine Society, past secretary, Endocrine Society of India, and joint secretary of Karnataka RSSDI, vice president of Karnataka RSSDI. He got the award of Dr. Nadagowda Oration Award, 2014 RSSDI Oration, and Sunil Kumar Basu Oration Award, and published more than 90 publications and has done more than 80 clinical trials. So I would request the two chairpersons to take us through the next topic, and I invite Dr. Nihal, and they will introduce Dr. Nihal, who doesn't need any introduction, but just for... Is it visible?
Yeah, it is visible. Ganapathy will do the honors. All right, you do, sir. Yeah, please. I must tell you, it has been a pleasure seeing Nihal growing through all these decades into a very astute clinician and a very significant contributor to endocrinology in the country. An excellent researcher and a par excellent teacher. Literally been a part of all these academic forums for such a long time. Now he's been working at CMC Vellore and is heading Department of Endocrinology there and holds many positions there and quite few hundred publications in peer-reviewed journals, many orations and in fact, I was once a part of one of the meetings, they call it a winter or summer meeting, I don't know. No, there was a pituitary symposium there with some of the stalwarts. I was really amazed at how that institution is run and how this young man has taken over the mantle of a very senior and significant contributor in the field of endocrinology. Without getting into the nitty-gritty of it, I would request him to start his talk. If you look in totality, in the field of medicine in general, paraneoplastic syndromes have been an enigma, and endocrine paraneoplastic syndromes have unfolded many components of basic sciences, how the cell regulation occurs, and how differentiation occurs, and how de-differentiation occurs. And ectopic ACTH production probably is the commonest endocrine paraneoplastic syndrome that we clinically see, even though, if you look at published data, many tumors would be, if you do immunohistochemistry, you will find many hormones in those tumors that are resected. But the one hormone that makes a significant clinical difference and that we need to understand and manage in our clinic, particularly in tertiary care institutions where, many difficult cases are referred to. Probably an ectopic ACT production would be something that all of us would need to handle and need to know how to handle it, how to suspect it and how to manage it and how to treat it. Over to Dr. Nihal for his oration.
Thank you, Dr. Zargar, for that kind introduction. Thank you, Dr. Mala, for inviting me to give this talk. So as Professor Zargar has said, I will be talking about ectopic ACTH-dependent Cushing's syndrome. Let's go through this from a perspective of a lesson learning process. I'll be talking about the Etp presentation and approach to diagnosis, some tackling of opportunistic infections, false localization, why size does not necessarily matter, occult disease, prolonged medical treatment, and delayed and secondary presentations. So just for the broadness of this audience, we knew that pituitary disease is the most important cause for ACTH producing tumors. Having said that, there are a number of conditions which might result in ectopic ACTH producing syndrome. And essentially they include bronchial carcinoid, malignancies of the lung, thymic carcinoid, pancreatic tumors, medullary thyroid cancer, pheochromocytomas, and occasionally you may not find or get a definitive cause. So let's first talk about the Etp presentation, an approach to diagnosis and how we tackle opportunistic infections. This is a 19-year-old medical student who presented with hypertension during screening for medical admission in August 2012. He had hypertension and was asymptomatic for the next 3 months. They thought it was white-collar hypertension, left it alone. Subsequently, he had weight gain for over 40 days, high blood pressure recorded at 160/100, swelling of the lower limbs, facial puffiness, and other features of Cushing's syndrome in addition. So progressive weakness of the lower limbs, bedbound since the initial part of the year, severe hypokalemia, lower backache, and psychosis. There was polyuria and polydipsia found to have high sugars, and he was started on insulin 1 week prior to coming to us. Initially, his potassium was extremely low, and he had severe hypokalemic alkalosis. So the first kind of question that one would ask is, what is the type of Cushing's that this patient has? This is a young male with hypertension, diabetes, rapidly progressive symptoms, and gross hyperpigmentation with severe hypokalemia. Therefore, with this constellation of severe hypokalemia and very rapid progression of symptoms in a young male, this combination would make us think of an ectopic ACTH producing Cushing's. This is his appearance, dull, apathetic, got generalized pigmentation, and his blood pressure when he came to us was just borderline. And therefore, what would one do at this particular point of time? So we go through the process of screening for Cushing's in this very obvious clinical case, and we find that the cortisol levels are elevated in the basal state, the midnight cortisols are elevated, and both post-low dose and high dose cortisol levels are not suppressed. In fact, they're extremely high. The urine-free cortisol levels are also sky high, almost something like 100 times the upper limit of normal. And the ACTH levels are well above the cutoff range in our lab, are almost 20 times the upper limit of normal at 696. So this patient had initially come in and had an ACTH measured. The initial physician had saw him and asked for an MRI of the pituitary, thinking, of course, this must be the commonest cause. But what the MRI does show is a slightly bulky pituitary, and one should go into looking at an MRI in an objective sense. So when we look at the pituitary, one would apply the Elster staging, and the minimally convex upward look, almost spherical look, is seen in grade 4 and grade 5, which might indicate a pathological lesion. Now, this is a bulky pituitary, but having said that, there is no definite focal lesion. This is the CT of the abdomen, Now, considering that the high dose is not suppressed, the high dose dexamethasone suppression test, we thought this was an ectopic ACTH producing syndrome. The CT abdomen shows bilateral hyperplastic adrenals, very large, bulky adrenals. And objectively, how do you figure out whether this is enlarged or not? Well, there are Indian studies and one done from our center, which have shown that the average size of an adrenal gland is larger on the left than on the right and is larger in males when compared to females. Well, this is almost 4 times the normal size of a normal adrenal gland that we saw in our patient. As you can see over here, bilaterally hyperplastic adrenal glands. The CT thorax was also done, and this shows a bulky lesion in the anterior superior part of the mediastinum. So this was followed up by a Dotenok PET scan, which showed an anterior mediastinal soft tissue lesion, which is in the location of what would be the thymus, and is possibly the site of an ectopic ACTH producing tumor. So the patient was subjected to a thymectomy by the thoracic surgeons. A total thymectomy was performed, and the thymus was found to be adherent to the innominate vein, and the tumor in the left lobe of the thymus was dissected, and the left phrenic nerve was preserved. So after the surgery, he did not have remission. There was persistence of hypokalemia, hyperglycemia, hypertension, and edema, and the ACTH levels were also elevated. So for all patients with Cushing's, obviously, you need to have a lifelong follow-up. This patient, because of his aggressive, persistent disease, underwent a bilateral adrenalectomy shortly later. And you can see over here, a week after surgery, this is his sternotomy site. You can see on the chest X-ray, he develops cough and fever, and you can see infiltrates which are dominant on the left side of the lung. Now, of course, this could have been a run-of-the-mill post-operative respiratory infection, which he could have had. But having said that, this might be something else. So the differential diagnosis that one needs to think about over here are a pyogenic pneumonia, nocardiosis, pneumocystis carinii, and tuberculosis. Now, you should think about acute opportunistic infections in this kind of a situation, particularly if there's disproportionately fever is not significantly elevated. So nocardia and pneumocystis carinii are particularly important to think in this sort of situation. The patient was started empirically on norepinephrine and on trimethoprim sulfamethoxazole combination, and these medications were continued. In the meantime, within 3 days, we actually got through the bronchial lavage neocardial species which were present. Filamentous gram-positive organisms were picked up on the smear. This is his subsequent X-ray done 2 months later, and he is asymptomatic. So in Cushing's, we need to keep the index of opportunistic infections very high and treat empirically fast and first. That's really important because otherwise one might succumb to these opportunistic infections, and I'll show you data as to how important this is. Our patient had, for his residual ACTH producing thymic tumor, chemotherapy. He was given temozolomide, an alkylating agent, along with capecitabine for the residual tumor. And this is his progressive photographs. As you can see, he still comes to us for follow-up 9 years later, and he's doing pretty well. Now, this is our experience of ectopic ACTH Cushing syndrome, which has been published in endocrine practice a few years back. And we did compare them with controls of pituitary Cushing's to try and see how they would differ clinically as well as biochemically. And what we can see over here is that the frequency of central obesity is actually much less. In ectopic ACTH, they do not have central obesity as a major presentation. It's only around 14%. They are much more florid in their hardcore clinical features of Cushing's, like easy bruisability. Pigmentation is much more florid. Edema is also much more prominent than those with pituitary Cushing's. And what was really striking is that the likelihood of developing opportunistic infections is very, very high. Almost in pituitary Cushing's, by and large, it is not a major presenting feature. Biochemistry is very dramatic. Baseline cortisols are elevated. ACTH is invariably extremely high, usually much more than 100 picogram per ml in our lab. The midnight cortisols are elevated, and the urine-free cortisol levels show absolutely or virtually no overlap with those patients who have pituitary Cushing's. They're extremely high once again. So if you have a good UFC assay and a good ACTH assay, these can actually help in you predicting your possibility of ectopic ACTH versus Cushing's syndrome before doing the high-dose dexamethasone suppression test. Remember, the high-dose dexamethasone suppression test may not be suppressed in about 15% of patients who have pituitary-dependent Cushing syndrome. Because they have a highly catabolic state, the serum albumin is also extremely low. And of course, as I mentioned to you, they have hypokalemic alkalosis as well. So here's another patient, an 18-year-old who came with a history of bloody diarrhea for 2 years, evolution of Cushing's features over just 2 months, biochemically high ACTH, cortisol, and UFC, which were all in the range of what might be an ectopic ACTH. We evaluated him in detail and even did a PET scan, but did not find anything. So therefore, occult. Now, when he came to us, he came with this bloody diarrhea, and a CT of the abdomen showed, of course, the adrenal hyperplasia, but also showed a large hepatic fluid containing spaces, which were basically abscesses, and an aspirate and a blood culture showed an odd organism called Advesilla tarda. Now, you get all these kinds of exotic infections, and the reason for this is this gentleman had gone fishing about 2 weeks before, and this is a microorganism found in fish usually, and not in humans, but in a human with Cushing's, this can be pretty much dangerous. The next lesson I'm going to talk to you about is about false localization. Here is a patient once again with features of Cushing's, acne, generalized swelling, diabetes and hypertension, and biochemistry once again, which is pretty classical. High UFC, extremely high UFC levels, which are reminiscent of ectopic ACTH and high ACTH levels as well. Now, this patient had actually had an MRI outside, which was actually the red herring. The red herring in the sense that you can see 2 microadenomas on the MRI on either side of the stalk. And this, if you remember once again, the other patient whom I had shown you also showed a bulky pituitary, the first patient whom I had just talked to you about. The patient at another center underwent a transsphenoidal surgery, but the biopsy was not suggestive of an ACTH secreting adenoma, and his cortisol levels persisted to be high. Now, this basically patient came down to us, and the biopsy was reviewed, and it was suggestive of nodular hyperplasia and not a pituitary tumor. The reticulin fracturing was not present. So he had a persistent hypercortisolemic state. The DOTA PET done at our center showed a lesion in the parenchyma of the lung, which is pericardiac, and this indicated the possibility of a bronchial carcinoid over here. So this patient underwent bilateral. Now, the patient, in fact, was given the option. We, in fact, told him there's a possibility, yes, we can go ahead with a lobectomy of the lung, but he said, no, I want a guarantee for a cure. We negotiated with him for almost 2 or 3 weeks, and finally he decided, if you're not going to cure me, and if you think there may be a malignancy in my lung, or it's a slow-growing tumor, which may not be totally removable, then I'd like a total cure. And we went ahead with an adrenalectomy. This is a little unusual based on the patient's request, but this is what we pursued finally, and primarily eradicated Cushing's. He has been on follow-up thereafter, which has shown a lesion which is very similar, present in the lung, and persistent. Post-operative serial ACTH levels show a more or less persistent elevation. He last came to us for follow-up in 2019, and he remains otherwise asymptomatic, other than showing some pigmentation due to the ACTH levels. Now, a pituitary MRI in this situation is always a difficult proposition. You can get a bulky pituitary, or you can get nodular changes because of concomitant CRH secretion. Many of these patients who produce neuroendocrine tumors that produce ACH may also produce CRH in addition, and this can be responsible for the nodular changes. And CRH is generally not a measurable hormone in most labs across the world. In fact, we sent a sample to Oxford, and they were not able to actually find this, but they said there's possibility of CRH lurking around, which might be causing the nodular changes in the pituitary in this situation. The next lesson is size does not determine the severity of a neoplasm. 29-year-old gentleman with recurrent episodes of acne and muscle weakness, hypertension for 4 years before he came to us. He was given diuretics elsewhere, all kinds of treatments were given, even had a workup for Cushing's before he came to us, which was negative. And then when we saw him, his cortisol levels were elevated. High UFC again, and ACTH levels which are extremely high. So this patient once again had a pituitary outside, lo and behold, which was normal, a pituitary MRI, and it was possibly, we thought, a Rathke's cleft cyst, and the CT abdomen showing hyperplasia of the adrenal and a thymic mass. So patient had a total thymectomy, hard 4 centimeter mass infiltrating the walls of the superior vena cava, and this was stuck to the pericardium. And here you can see there was a thymic neuroendocrine tumor. The ECTH immunostaining was present as well, and this patient essentially had a thymic carcinoma. Patient had carboplatin-based chemotherapy and relapsed in 2 years' time. Subsequently had lutetium therapy after a DOTA PET scan was still shown to be positive, but subsequently had progression of disease and death after 2 doses of lutetium. So what is our series on ectopic ACTH show? There's a male predominance of 5:2. Thymic and bronchial carcinoid and lung carcinomas are a dominant cause, 17 out of 21, 80%. So basically, and 19 out of 21 therefore have the etiology above the diaphragm if you add on medullary thyroid cancer. The CT thorax or a PET CT clinches the diagnosis in 80% of cases. All thymic carcinomas have local metastasis at diagnosis at diagnosis or after surgery in our series, and there is a 50% recurrence of lesions in our patients who had bronchial carcinoids. Our next lesson is that of occult disease and a story of prolonged medical treatment. 55-year-old man came way back in 2006, generalized edema, swelling of the face and body, pigmentation. He had ecchymosis present, features of Cushing syndrome, and his potassium was extremely low. I remember this gentleman, he came in and he was very refractory to treatment. We gave him 40 grams of potassium infusions per day for a total number of 3 days. We had given him spironolactone for 300 milligram for a week, and his ACTH levels were very high. His imaging at that time was normal, and in 2006, we did not have PET scanning in the institution. Medical treatment was considered as an option. He was given ketoconazole initially, but developed hepatitis. And therefore, we reviewed the possibilities. Of course, these are centrally acting, which do not work in ectopic ACTH. We thought ectopic ACTH because of his severe disease, hypokalemia and alkalosis. We thought of drugs which might work peripherally, but the ketoconazole option was abandoned because he had hepatitis. So we finally opted for something we had used in the past a lot, and that was mitotane. Mitotane, of course, is feared by a lot of physicians outside, but in our experience, the doses you give for Cushing's are much less than what you give for adrenocortical carcinoma, where you need huge doses of 4 to 8 grams. But in these situations, you can manage with doses of less than 1 to 2 grams per day. So clinically, he was started on mitogram 2 grams per day, and he has been followed up for the last 15 years. He's had 2 FDG PET scans, which are negative, 2 DOTA PET scans, which have been negative, and he's asymptomatic on mitotane therapy. So our experience is that with ketoconazole 200 to 1200 mg per day, we have an 80% response. There are patients who are refractory or become resistant to ketoconazole, and then we use mitotane treatment in those situations. Finally, delayed and secondary presentations is what I'll be covering. 67-year-old man with the typical features of Cushing's, but also had weight loss of 10 kgs for 3 months. He had episodes of palpitations and panic attacks and a sense of impending doom. Known hypertensive, diabetic for a long duration of time, but had also been on antihypertensives for increased doses for a year and had a right adrenalectomy for a pheochromocytoma 2 years before. He had a carcinoma glottis, which is unrelated, and underwent a cordectomy at that point of time. So you can see high blood pressure, severe proximal myopathy, no hyperpigmentation, bruisability or stria, but weight loss. Biochemically, once again, hypokalemia, grossly elevated midnight cortisol, very high urine-free cortisol, and very high ACTH levels with high urinary norepinephrine levels. So what could this be? Sources: a recurrent pheochromocytoma with ACTH production, newly emergent malignancy because he's had a previous vocal cord malignancy. So could it be a new lung malignancy or a carcinoid or something else? Yeah, this is the FDG PET, which shows the surgery on this side and multiple lobulated small discrete enhancing lesions in the right suprarenal lesion and a diffusely enlarged enhancing left adrenal gland. Severe disease, unfit for surgery. Consider medical treatment. So we started him on intravenous edomidate, and this resulted in some degree of improvement. Also started on alpha-adrenergic blockers and taken up for bilateral adrenalectomy after weeks. But he was found to have, unfortunately, diffuse peritoneal metastasis at laparotomy. And here you can see chromaffin stains, and they were also positive for ACTH. Diffuse spread of disease, only one adrenal was removed at the time of surgery, and we planned for an MIBG treatment because he was MIBG positive. He needed etomidate, mitotane, ketoconazole postoperatively, all in combination, very refractory, and finally died of pneumonia as well. So similar experiences with late onset presentation in 3 patients with medullary thyroid cancer with 100% mortality, unfortunately. So let me summarize. Ectopic ACTH-dependent Cushing's have a more severe clinical and biochemical phenotype compared to pituitary disease. Supradiaphragmatic disease is present in 85% of patients. Local metastasis is almost invariable with thymic disease. Opportunistic infections are common and need early and aggressive treatment. Medical therapy is effective as bridging treatment before surgery or for long-term treatment. Early adrenalectomy, a very important lesson preceding definitive primary tumor removal, is a frequent thing that we do because it can prevent severe acute morbidity. Thank you for your patient listening. I'd like to acknowledge my entire department, allied departments who have helped us with treatment, endocrine surgery, nuclear medicine, biochemistry, and radiodiagnosis.
And that was a very wonderful talk, justice done to a very difficult time in 15-20 minutes. And it just tells us about the spectrum of this disorder, biological as well as clinical. Couple of questions, Nihal. You talked about that first patient who had a thymoma, and in that there was a tumor. If that was surgically removed and still had some features of Cushing's, means either the surgery was not adequate or tumor possibly was elsewhere. You need to do the bilateral adrenalectomy. Your comments on that?
Yeah, thank you, Dr. Zargar. The problem is that most of these patients have local metastasis, and they have adhesions to the vasculature in the lung, notably the venous vasculature, and so the brachiocephalic vessels, etc. And so they are usually very difficult to resect in these situations. So it is local metastasis which we are dealing with in these patients, which is a big challenge. And of course, therefore, we have to subsequently resort to chemotherapy and, of course, early adrenalectomy once again for remission of the Cushing's per se.
Good. About that fourth case, where you went into pituitary a couple of times and then ultimately it proved to be a carcinoid. One thing that needs to be understood in the current times, given the accuracy of current imaging tools, you will have many pituitary incidentalomas. And when you have a setting like that, you might think there's a pituitary tumor from which ACTH is coming. It may not be coming. And there is data which has shown up to 8 to 10% of cellular radiology done for trauma, if reviewed, might have an incidentaloma in the pituitary. So that part should be also understood, that there might be an OR case that might explain that situation in your case number 4.
100%, Dr. Zargar. The fact is that the patient had these procedures done elsewhere before coming to us. And I'm certain that in most reputed institutions nowadays, they'd be very cautious in interpreting an MRI in these situations. 10 to 15% of MRIs will show something. And particularly here, remember that these ectopic ACTH producing tumors co-secrete CRH along with the ACTH. And therefore, a swelling in the pituitary could always happen.
Absolutely. Absolutely. Ganpati has a comment or two.
Yeah, actually, just to talk about the thymoma thing, we have had, of course, not presenting as Cushing's, but then the most important reason, thymoma are very aggressive tumors, and they have a malignancy rate of up to 70%. So that's one thing with the thymoma. Did you think about men or something like that? Had you done a work of men?
You're right.
In there?
So we, in fact, in all our patients with thymoma, we always look out for MEN1 as a potential possibility. These 4 out of the 5, I think 4 patients did not have MEN1. One patient eventually had a family history of MEN1, but this was the index presentation, and subsequently there were no other occurrences of any other features of MEN1 in those patients. We have had, of course, most of the, so that's it about the patients with thymomas who have MEN1. The MEN1 presentation from another site will be actually prominent. For example, GH producing adenomas is something which we have seen with greater frequency, and of course hyperparathyroidism.
Yes, hyperparathyroidism. Yes. Yeah. Well, how about in the medical line? What about your experience with mifepristone?
Yeah. So the problem, as you know, with mifepristone is actually monitoring these patients after giving them mifepristone. It is very difficult. It's a challenging thing, especially since very often what you're trying to do is achieve borderline control in these situations. When you go up to maximum doses of ketoconazole, or if you use mitotane, you reach this point of borderline. And we use the urine-free cortisol actually for monitoring these patients because it's very useful. Now, with mifepristone, you have a problem with monitoring these patients and trying to figure out whether they're truly in remission. You can go clinically, but that's really not enough because some of these vague symptoms that they have, like diabetes or hypertension or whatever, are not necessarily, they may or may not remit, and you still are in a quandary as to whether. So we haven't really used mifepristone in our armamentarium because of our apprehension. I'm not saying that you can't. You could always give it a try, but this is our basic issue about monitoring these patients long term.
Okay.
I think,
So Nihal, there's one question from the audience. Is there any ACTH cutoff between pituitary and an ectopic Cushing's?
Yeah, I think our data has quite clearly shown, and even other centers have shown that usually if you have an ACTH level more than 100, of course, with all the other clinical features in addition to it as well, the likelihood of it being a pituitary microadenoma is going to be less. The chance of a pituitary microadenoma having an ACTH more than 100 is less than 10%. And of course, you can't miss a pituitary macroadenoma. So that's not an issue over there.
Yeah, I think we had recently in the last 1 month 2 cases of bronchial carcinoid. See, one usual thing what normally we say is they are all slow growing tumors. They don't have robust secretions. But then here, both of them are having very like what you have presented, very high levels of cortisol, not separable, 50, 60, and both of them in the PET CT showing bronchial carcinomas. They are going to get operated shortly. So very high levels of cortisol with hypokalemia presentation. 2 patients in the last 1 month. This is after 6-7 years we got 2 in 1 month.
I'm sure if we want to go on, we'll go on for a long time because this is a time to have some respite from that cardiometabolic syndromes into hardcore endocrinology. And I'm sure if we are unleashed, Krishna and Das's program would go haywire. Thank you so much, Nihal. It was a pleasure listening to you. Such a wonderful talk.
Thank you so
Over
much.
to Mala for the next session.
Thank you, the chairpersons, both Dr. Zargar and Ganapathy, and thank you, Dr. Nihal, for that excellent, very hands-on presentation. And we have around 150 young endocrinologists listening to us. So thank you very much for the very practical session. And the next session, we have the three same persons there. We have Dr. Abdul Zargar and Dr. Nihal Thomas, who would be chairing the session, and we have Dr. Ganapathy, who will be talking to us about metastatic pheochromocytoma and abdominal paragangliomas. So I don't think they need any introduction. So over to Dr. Ganapathy.
Thank you, Dr.
You have
Mala.
to do without second introduction.
First of all, let me thank Dr. Mala Dhamalingam for inviting me. Yeah, I made this presentation to the tune of the students and not for the general audience. So my topic is on metastatic pheochromocytoma and abdominal paraganglioma. Yeah, so malignant pheos and paragangliomas, they are rare endocrine cancers. So all the pheochromocytoma paragangliomas are believed to harbor malignant potential. About 10 to 15% of the pheos and up to 50% of the abdominal paragangliomas will become metastatic. So what is the definition of a metastatic pheo? There's currently no histological, biochemical, molecular, or genetic marker that can clearly differentiate benign from malignant. So the definition of these malignancies rests on the presence of METs. The term malignant pheo and benign pheo from the 2004 WHO classification of endocrine tumors was abandoned in the current WHO classification of endotumor. So the term malignant is replaced with metastatic in this group of tumors. And metastatic pheoparaganglioma, this combination is known as PPGL is pheochromocytoma paraganglioma, is defined as such if the location is normally devoid of normal chromaffin cells. The regions where you don't find this and you find these chromaffin cells, then you think. So let me begin with the case. A 31-year-old female came with recurrent episodes of palpitations, headache, and vomiting since 6 months. Weight loss, 8 kgs in 6 months. Detected with hypertension 5 months back. No family history. 24-hour urine metanephrines 3.24 milligrams per 24 hours high. Serum chromogranin high. CCT abdomen, it showed a retroperitoneal 7/8 enhancing lesion with areas of necrosis and hemorrhage. Post-contrast 140 HU. So it was suggestive of retroperitoneal paraganglioma. Now, is there a risk for METs in this patient? So coming to parasympathetic paragangliomas, also known as the glomus tumors, they are usually located in the head and neck, non-secretory. They rarely metastasize, less than 10%. They do produce actually hormones, especially they could produce dopamine. So mutations in the gene that code for the different subunits, the SDHA, B, C, and D of the succinate dehydrogenase enzymatic complex and its cofactor, SDHAF2, frequently predisposed to multifocal parasympathetic paragangliomas. Sympathetic paragangliomas are usually located in the chest, abdomen, and pelvis. They typically produce catecholamines, only noradrenaline, because you require the PNMT, and that's not there. And they exhibit higher rates of metastasis, up to 70%. So the parasympathetic, less than 10%, and sympathetic, up to 70%. So pheos usually release catecholamines, adrenaline and noradrenaline, the pheochromocytoma, which is adrenal. Some are metastatic in 15 to 20%, so less often metastatic. Now, why do they produce adrenaline? Because they have the PNMT, the adrenal glands has the PNMT. So the typical metastatic sites are regional or distant lymph nodes, bone, liver, and lungs. Rarely, they can metastasize to the breast, ovaries, pancreas, brain, and skin. So are there any biochemical markers for METs? The best biochemical method for diagnosing pheoparaganglioma is plasma-free metanephrines and normethanephrines with a sensitivity of 90 to 100 and a specificity of 80 to 100%. What about chromogranin A? A sensitivity of 98% and specificity of 97%. The best combination of sensitivity and specificity is obtained by combining plasma chromogranin A and metanephrines. And this has been recently coupled to high pass scores and adverse clinical events. So probably a new non-invasive marker to assess metastatic potential if you have a high levels of both chromogranin A and METs. So methoxytyramine, a dopamine metabolite, it's measured in the plasma, has been shown to be an important biomarker for metastatic PPGL. So when you have metastatic PPGL, one of the markers we have to measure is methoxytyramine, which is a dopamine metabolite. And usually it points to mutations in STHB, D, and C, STHB being the main one. Up to 25% can have metastasis. Now coming back to a patient, does the patient require genetic testing? All paraganguliomas are considered mostly heritable, are considered the most heritable of all the tumors. And all these paragangliomas must be referred for genetic consultation. So coming to the clusters, you have cluster 1, which is hypoxia-related cluster. Cluster 2 is kinase-driven cluster. Cluster 3 is overexpression of the Wnt signaling pathway. Cluster 4 is overexpression of adrenocortical genes. So cluster 1 is related to pathways associated to hypoxia. So you have in them mutations in the VHL and the SDHX gene family, mostly STHB and D. They have a high risk for METs. And the most notable predictor of aggressive clinical behavior is the presence of STHB mutations. And these mutations predispose the familial paraganglioma pheochromocytoma syndrome. This is tightly coupled to the development of abdominal paraganguliomas that are often metastatic. STHB immunochemistry has proven a valuable tool to triage cases for genetic testing. So coming to genetics in pheochromocytoma, there's a strong link between mutations in the Krebs cycle-related genes and metastatic properties. So if you have a germline mutations in mitochondrial 2 oxoglutarate malate carrier SLC25A11 or glutamic oxaloacetic transaminase 2 gene or dihydrolipomide S-succinyl transferase gene, they predispose to metastatic paragangliomas. Other non-mitochondrial related genetic aberrances coupled to metastatic paragangliomas include the MAML3, that is the cluster 3, and somatic mutations in the STT2 and ATRX and third promoter structural variants in non-coding. We don't do this. I think Nihal could throw light later on. What imaging methods are preferred in this patient? So we talked about genetic predisposition, which are the ones which are prone for metastasis. Coming to the imaging methods, CT scan is often the first modality on which an adrenal mass is detected. So there are some characteristics: spherical shape, sharp necrosis, ring sign are indications that a tumor is a pheo. It can be ruled out with 99% sensitivity if the HU is less than 10 on an unenhanced CT. Post contrast, it's highly enhancing, usually more than 130 HU. MRI with diffusion imaging techniques can even detect small tumors down to 5 millimeters, high sensitivity, useful in children, pregnancy, or somebody is having a familial pheo or a genetic where you know that they'll have to be screened very often. In them, actually, MRI is good. And MRI is also good for non-adrenal lesions also. Functional imaging. So MIBG. So this is a norepinephrine analog accumulated in the adrenal medulla and the tumors originating from chromaffin tissue. MIBG with 123 iodine is used for detection and staging of PPGLs. Sensitivity between 28 to 100%, higher for pheos, 85 to 88%, lower for paragangliomas, specificity between 70 to 100%. So normally we have actually reduced the usage of this. The reason being, normal adrenals can also take up in up to 50 to 60%. And even the paragangliomas, 50 to 60% may not take up this MIBG. That's the reason. So we use it mainly if you have post-op cases, you want to look for residual disease, then you can actually look for this. Or in the adrenal, if the tumor is very large and we are sure there are some METs, actually, then you can actually go for this. So in STHX mutations carriers, sensitivity is lower than other imaging methods, especially in patients with thoracic paraganglioma. The other functional imaging include FDG PETs. This is useful for METs, especially of the STHB1. Few chromosomes usually have increased yet often variable FDG uptake, low specificity. The other one is a 11C hydroxyepidin PET, not universally available. Sensitivity for FEO and paraganglioma 96%. The good positive and a negative predictive value of 96 and 93 to 99% respectively, but then not available. This is the one which is coming up a lot, functional imaging. 68 gallium DOTATOC or DOTATATE PET targets mainly the somatostatin receptor 2. Sensitivity for metastatic PPGL is around 92 to 100%. So which imaging is preferred? So I talked about the various imaging, which is the one which is preferred. Sporadic and inherited FEOs, NF1, the RET, VHL max, except the STHX, 18 DOPA PET, first choice, the second choice being the DOTATATE, and the third being FDG PET. Extraadrenal sympathetic or multifocal or metastatic or STH mutation, DOTATATE PET, first choice. What are the predictors for metastasis? Size of the tumor. The moment you find a size of the primary tumor being more than 5 centimeters, location, extraadrenal especially, presence of STHB mutation, sympathetic paragangliomas exhibit a high rate. I told up to 70%. So at the time of diagnosis, patients with any of these 3 clinical predictors of METs may benefit from functional imaging studies. Histology, well circumscribed. Classical architecture include an which is referred to as Zell-Ballen against a well-vascularized stoma. Tumor cell nuclei display a vesicular chromatin and visible nucleoli. Cytoplasm is often granular and intense basophilic. Invariably express neuroendocrine markers such as chromogranin A, synaptophysin, islet-1, INSM1. They are most often keratin negative and GATA3 positive with few exceptions. This is for. So is there a histological scoring for predicting aggressive biological behavior? Yes, you have what is known as a PASS scoring. That is a pheochromocytome of the adrenal gland scaled score. It has a high negative predictive value. A value less than 4 almost always is associated to a benign clinical course. So you can see you have a total score of 20. Like you have a central or confluent necrosis 2 points, high cellularity 2 points, like that. Mitotic index 2 points, atypical mitosis 2 points. So overall you have 20, less than 4, you can say it's benign. Another one known as a gap algorithm, grading system for adrenal FEO and para, designed for both FEO and abdominal paraganglia. It expands on the PASS system by also including biochemical type. That's a type of catecholamine production and immunohistochemistry of Ki67 analysis. What are the treatment options? Surgery. More than 90% of patients with non-metastatic disease treated with surgery are alive 5 years after initial diagnosis. It could be open or laparoscopically. Now it's becoming more often laparoscopic. So this is selected on the basis of presence of clinical predictors of aggressiveness. In patients with subdiaphragmatic primary tumors larger than 5 centimeters, open lap preferred. It's also an option in patients with paraganglioma that are metastasized only to regional lymph nodes. Advantages in metastatic FEO paraganglioma include improved survival after primary tumor resection in patients with distant METs. Resection substantially decreases symptoms of catecholamine excess, prevents potential complications related to the tumor's anatomical location, increases the efficacy of subsequent systemic therapies such as chemo and radiopharmaceuticals. Pre-op management, I will not go into this because you all know this. Yes. Now coming for management of hormonal manifestations. So metastatic paragangliomas are usually large. They have excessive amounts of catecholamines and many of them release dopamine. As you know, its excess does not lead to hormonal disease. So the catecholamine release is proportional to the tumor size. So hormonal manifestations are more overwhelming than in non-metastatic PPGL. Radiation therapy can palliate the primary tumors of metastatic head and neck paraganglioma, bone mets, or mets in location at high risk for complications, supraclavicular regions. Stereotactic radiosurgery, proton beam radiation therapy are helpful in treating skull base and neck paraganguliomas. Stereotactic radiosurgery has also been used for metastatic paraganguliomas that spread to the spine and other sites. Radiation therapy, epidural disease, and spinal cord displacement surgery is the first-line treatment, followed by stereotactic radiation surgery followed by stereotactic. Coming to ablative procedure for local non-surgical management of metastatic FEO of para, radiofrequency ablation, cryoablation, or percutaneous ethanol ablation. So these may palliate metastasis-related pain, reduce catecholamine excess, and stabilize mets in critical anatomic locations. If you have a bone mets, you can give antiresorptive with denosumab or bisphosphonate, especially zoledronic acid. What about the value of iodine 131 MIBG? So the value of this is mainly for treating this in metastatic is based on its affinity to the norepinephrine transporter located in the cell membrane of these tumors. You have two types, the low specific activity one and the high specific activity iodine 131 MIBG, and the one which is recommended by the FDA is the high specific activity. Indications are patients with progressive and unresectable MIBG await metastatic FEO or symptomatic disease that's not amenable to loco-regional control or difficult to control with alpha and beta blockers. And the clinical responses are expected to be inversely proportional to the size of the tumor. Adverse effects include bone marrow suppression, nausea, vomiting, fatigue, dizziness. Coming to chemotherapy, when do you use it? Unresectable and progressive metastatic FEO paraganguliomas, especially in patients with high tumor burden and rapid progression. The usual one which has been used is the CVD, that is cyclophosphamide, vincristine, dacarbazine is the most common regimen used to treat this. You'll have to be very careful. Sometimes what happens when you give this, there's a destruction and there's a release of a lot of catecholamines, and it can produce what is known as Catecholamine Crisis, where the patient may go into a shock. And don't give up these patients. There's been instances where the patient recovered after 6 days because of the stunning effect which can happen. So don't ever give up when you give this therapy. Don't think the patient is dead. He could still recover and come. Temozolomide, orally administered drug that shares its active metabolite with dacarbazine, may be given as maintenance regimen to minimize risk of complication. It has been mainly efficacious in STHB carriers. Anti-angiogenic therapies. The metastatic one express angiogenic factors and the receptors, and subsequently these tumors are highly vascular. So they have tried tyrosine kinase inhibitors like axitinib, cabozantinib, lenvatinib, pazopanib, and sunitinib. Not so good results with this. HIF1 inhibitors, the cluster 1 ones. Abnormal activation of the hypoxia signaling pathway play a major role in the oncogenic potential of this. So especially they have used HIF2 antagonist has been evaluated for this. Then you have this DNA demethylating medication. The STHB mutations, they result in accumulation of succinate, which is an oncometabolite that results in DNA and histone hypermethylation. So they tried using decitabine, and guanidicitabine has been used in phase 2 trials. And then you have what is known as the peptide receptor radionuclide therapy. This uses a somatostatin analog coupled with radionuclide emitting beta radiation. And the radiopharmaceutical used is yttrium-90 labeled DOTAO, tyrosine 3 octreotide, DOTATOC, and 177 lutetium dotatate. Immunotherapy. So the pseudohypoxia, once again the cluster 1, may prevent the immune system recognition through inactivation of the cytotoxic T lymphocytes, activation of immune suppressive monocytes, and increased expression of immune checkpoint proteins, the PD-1 and the PD-L1. So they are tried using the pembrolizumab, nivolumab, and interferon alpha. Similarly, mTOR inhibitors have also been tried. 2 small reports, some effects, not very convincing. So you can see the list of drugs which can be used actually. They have used ipilimumab, pembrolizumab, cabozantinib, pazopanib, sunitinib, cabozantinib, acting on the VEGF, you can see here. They even tried 131 MIBG, this is known. Cyclophosphamide, this is the one which acts at this level, and the radiopharmaceutical lutetium-177 dotatate. So you can target many things. So acting at the level of the M also, the everolimus has been tried. HIF2 alpha has been acted. So coming to the treatment decision, so I told about what are the choices available. So the treatment of patients with metastatic FEO is determined by several aspects: tumor burden and speed of progression, patient's symptoms and performance status, results of functional imaging studies, treatment availability and cost, and clinical experience. Patients with minimal or slow growth, they may benefit from observation or intervention such as anti-resorptive medication, surgery, or ablative procedure. Patients with progressive tumors, skeletal-related events, large tumor burden regardless of prior evidence of progression, or symptoms of hormonal excess not controlled with alpha or beta blocker need systemic therapy. So recommended first-line treatment for patients with metastatic FEO and paraganguliomas. So if it is gallium avid, 120, you can use or 123 MIBG avid. You can use lutetium dotatate or MIBG 131 depending on the uptake intensity. If it is MIBG non-avid and gallium avid, lutetium 127. Non-gallium avid but MIBG avid, iodine 131 MIBG. Suppose they are non-avid to both of them, people have tried temozolomide if they have a low proliferative activity. And if you have a high proliferative activity, the CVD, cyclophosphamide, vincristine, and dacarbazine. A tumor growth of at least 20% when compared with baseline or the development of a new lesion over a period of 3 to 6 months indicate the need for systemic therapy. For abdominal paraganglioma or metastatic paraganguliomas, dotatate therapy is more effective. In patients with very low proliferative activity, either wait and watch or primary treatment with long-acting somatostatin analogs may be considered. This is what you do. So you are treated them with alpha beta blocker, if possible, surgically debulk. If there is a rapid growth, chemotherapy with CVD. Slow to moderate growth, MIBG uptake is present, then you go for high-dose MIBG treatment. MIBG uptake is not there, then you can go for novel targeted therapy. If it is slow to moderate, that is lutetium, dotatate radiotherapy, tyrosine kinase inhibitor, you can try. So once again, if there is no response to MIBG and no response to this rapid growth, go for chemotherapy. So to conclude, all FEO paraganglioma carry metastatic potential. That's the reason we require lifelong monitoring in these type of patients. All the paragangliomas require genetic workup. Advanced and progressive metastatic disease carry high morbidity and mortality. No curative treatment options are available. Clinical trials are identifying therapies that could alleviate disease burden. Thank you for patient hearing.
Thank you so much, Dr. Ganpati. I think, if I look back at 40 years of my endocrinology, you won't believe it today. One single thing that has made a huge difference in cases like this is the evolution of imaging tools.
Yes.
We started, when I did my endocrinology in my younger days, not talking about post-graduation. For an adrenal tumor, we used to do an IVP and find out the location of the kidneys and at what level of vertebrae they were. Is the kidney pushed down? And then we'll think of an adrenal tumor. In fact, one of the cases I published from PGI in 1986, Etp Presentation as an adrenal carcinoma. And we did not even have, at that time, even an ultrasound available, making that diagnosis. And now, today, look at this refinement in the imaging tools, nuclear medicine tools, and then the hybrid forms of the nuclear medicine material, and picking up through the PET CT scans. That has revolutionized the thing. But with a caveat to the youngsters, many variations of normality are going to be labeled now as abnormal if we are not more than adequately treated, educated in these imaging tools. So in the long run, they stand a potential of causing more harm than good. Because, there may be so many abnormalities that are a part of routine. You see, like if you take out routine specimens of thyroid, 10 to 12% people will have a tumor which would never be functional. The same thing would be about pituitary. I was just, when Nihal was making that wonderful presentation, incidental tumors, we see so many of them now, adrenals. So that judiciousness is now required, that containment, rather than, randomly making a decision, probably for the youngsters, that some experience needs to be inducted into making more, final decisions, like that adrenalectomy, like that hypophysectomy. Some maturity needs to be put in.
Actually, when we had just passed out, we thought MIBG was the gold standard. And now we came to know 50% of the normal adrenals will take up, and 50 to 60% of the paragangulumas don't take up. And now for FDG PET, if the patient is on metformin, it will show a diffuse uptake in the intestine. So I think we must know all these negative things first.
Limitations.
Yes, limitations.
Extremely important when you understand the progress of an investigation, understand this limitation. Now I would like to make a comment before we'll take up some questions.
No, I think you're absolutely correct. I think we have to really go down to specifics when we look at these tumors. Ganapati mentioned a few very important things when he talked about, I think one is histopathological scoring, second is the isotope therapy, and the third was chemotherapy. When it comes to histopath, he rightly said that the PAS score has a high negative predictive value, but actually has a very poor positive predictive value. The GAP score, and particularly two variables on it, one is chlamydia necrosis, and the other one is pseudo-roset formation. If you see those, your likelihood of relapse is actually much higher. But if you don't see any of these, you just have to play it by ear and follow up every patient at least on an annual basis. I mean, you might be perfectly asymptomatic after 1 year of treatment, but you should follow them up on an annual basis. The second thing is, which you mentioned about isotope therapy, one of the unfortunate practical things is that MIBG is becoming increasingly difficult to get. And there's a strange political quirk to this whole thing. Number one, of course, the market for lutetium has increased, and so obviously things are moving in that direction. The other one is the largest provider for isotopes from abroad was actually Iran at one point of time. Now, unfortunately, due to various political issues, we can't get isotopes from Iran anymore to India, and that's a very, very sad thing. And we are forced to buy more expensive isotopes from Europe and the US. Oh, Europe rather, not US, France particularly. So that's also affected us in a big way. MIBG will, unfortunately, unless we really push hard, will die a natural death over the next few years. We'd be stuck with mainly lutetium, which is a shade more expensive. So that is how things are actually moving and progressing. The last one is, I think, chemotherapy for malignant pheos and paraganguliomas. The response, like you said, you put it last in the list, is kind of a last-ditch form of therapy. They really don't work particularly well. If you look at all the targeted immunotherapies available, the VEGF shows some promise, but most of the others, the TK inhibitors, etc., which work in other neuroendocrine tumors, don't seem to work particularly well in paraganglioma. So if, in a nutshell, I think these are the little bits of finer tuning which Dr. Zargar is mentioning, that we need to know what to do, what not to do, and be very careful about these things. One of the other things, and I think that perhaps would be neuroendocrine tumors in general. Remember, if you have a local metastasis and it's not functional, they can last and live with it for many, many years. So just follow up, repeat isotope scanning once in 1 or 2 years. And sometimes when you give targeted immunotherapy, they become more sick with that. So better leave them alone and live with their metastasis for maybe even 10 years sometimes.
Couple of words, Mala, before we take over some of the questions. When you look at these rare things, and there is no harm in talking to a senior colleague up and down in the city or country up and down, because the experience, like now, Ganpati just talked about the 2 cases of carcinoma with ectopic production of ACTH, and Nihal has a series. Sort of exchanging experience wouldn't be doing any harm to anybody. Just word up and down and might give an idea what needs to be done to a patient. And secondly, now what he also referred to this genetic assessment, particularly, if you are saying about 10 to 15% of these FIOs and paragangliomas would be malignant, 15 to 20% would be familiar. And the chance of pregnancy in them would be much higher. So, and now many of the endocrine societies and hypertension societies have given definite guidelines when to go for by genetic testing. And it's becoming relatively simpler now. We used to find it very difficult to get those metanephrines and nephrines done. Now it's being done on the roadside. I'm sure in a similar fashion, if some of us start picking up those techniques of really getting those genetic assessments done, we might find, I'm not talking about a metastatic pheochromocytomas. Some pheochromocytomas, which we otherwise treat as essential hypertension. As Nal was saying, some of those metastases, which may keep on lingering on, from the biological point of view, the metastasis may not be that violent or invasive. A person may live for a decade or two. Mala, any questions there? Mute.
You're muted.
Sorry. The questions are sort of repeated. Dr. Ganapathy has touched, but however, just for, again, you can reiterate, what is the best test to do for identifying it? You have mentioned, but you can just go ahead.
To begin with, we will actually do a CT. And then, as I told you, MIBG when to do. Suppose you have a large adrenal one more than 10 centimeters, or you have a METS. You're suspecting when you have more than 10 centimeters, what happens is there'll be definitely METS. So for that reason, we'll do then. And then follow-up of these patients, then we do an MIBG. But otherwise, we go for a PET CT. And the PET CT, I told you, for the various mutations, you can either do a DOPA. The advantage of the DOPA is it is not taken up by the normal adrenal glands. So that's the advantage. Or you can do a dotatate. That's the one with gallium 68. This one, dotatate, is supposedly now coming in a big way, especially for the metastasis and all. So I think we should go with gallium, then the DOPA, and then last, if you don't have these, then you go for the FDG PET. This is mainly for metastasis only. Otherwise, it's not that useful, the FDG PET. So
and I suppose the initial blood test would be a free plasma and the chromogranin A before you go into the imaging. Thank you very much, Dr. Ganapathy, Dr. Abdul Zargar, as well as Dr. Nihal Thomas. It was a very excellent session and we had a good interaction among all the faculty. If any of the faculty want to ask questions, please go ahead. All of them have joined. I can see Rakesh, Dr. Sriram, or Dr. Ali. Dr. Sriram has a question.
I think dotatate is fine.
You can see that. F-DOPA is not available. Dotanoc is only... Dotatate is not easily available. In Bangalore, dotatate.
That's fine.
Yeah.
Mala, thank you very much for asking me to be here this evening. It was wonderful, really, listening to Nihal and Ganapathy.
Thank you. It was really
what all we have been talking about and listening to for quite some time. It was timely needed to tell us that where the true endocrinology lies.
Thank you so much. And thank you both Ganapathy and Nihal. And we move over to the next session, which is the laboratory testing of Cushing, which will be delivered by Dr. Rakesh Sahai. And I am just sharing his CV. And it will be chaired by Dr. Sriram Mahadevan and Dr. Maithili. I especially thank both of them for having come. And Dr. Sriram has very poor internet, but he has saved enough of power for us. So I thank him for that. And Dr. Maithili is a very close friend, and I'm always happy to have her with me. And she is consultant endocrinologist at Visakhapatnam, former professor of endocrinology at Andhra Medical College, Visakhapatnam, founder secretary, Diabetic Child Society, Visakhapatnam, established the DEAR project at the Department of Endocrinology, and her areas of interest is type 1 diabetes, gestational diabetes, and thyroid disorders. And the other chairperson for this is Dr. Sriram Mahadevan, and he is currently professor and head Department of Endocrinology at Sriram Ramchandra Medical College, Porur, Chennai. And he's got the bronze medal for securing second position in MD internal medicine. It should have been silver, no? Why they gave you bronze? Currently working as vice president of Endocrine Society of Tamil Nadu and Puducherry chapter. And he has published various papers in national and international journals. over to the chairpersons to introduce the speaker and take it ahead. Over to Dr. Sriram and Dr. Maithili. I'm sharing Dr. Sahai's.
Sriram, please start.
Oh, you are asking me. Thank you.
Yeah.
I thought ladies first. Good evening, and it's a privilege and my pleasure again to introduce Dr. Rakesh Sahai, one of our close colleague for a long time now, almost 2 decades. I saw him first during my DM training when he came for the first ISBMR meeting all the way. And from there, I think it's a long academic journey he has had, and currently he is the President-elect of the Endocrine Society of India. He has a long year ahead with all fruitful things coming up, and he has been the organizing team of several endocrine meetings and instrumental, along with Dr. Sanjay Kalra and others, in getting the Indian endocrinology on the world map. And that itself will summarize most of his achievements on the academic and endocrine front. And needless to say that he has published several, both chapters as well as journal original articles, especially Indian perspective from southern India. And he is also working in the government setup also in Hyderabad and heading the Department of Endocrinology in the Osmania University. Over to you, sir, for today's another interesting topic.
Thank you. At the outset, I would like to thank Dr. Mala for inviting me to be in this program, and also to the chairpersons for the kind words of introduction. And we had 2 really excellent presentations by Dr. Nihal. He has actually discussed about all about most of the things which I'm going to discuss. So basically, I'm going to actually take a step backwards and discuss some basic aspects about investigation of Cushing's. And so that's what I'll be doing in the next 15-20 minutes or so. Let me share my screen. Is my screen visible?
Yes, sir.
Yes.
Yeah.
Put it on, yes.
Yeah. So thank you once again. Thank you, Dr. Mala and Dr. A.K. Das and others who are organizing this meeting for inviting me to be here. And so what I would do is that I would be discussing some of the basic aspects about investigation of Cushing's disease. And so I'll start with the case discussion, case vignette. This is a 22-year-old gentleman who was presented with gradual onset of weight gain. He's got abdominal distension and thinning of his arms and legs. He gave history of fatigue and dyspnea on exertion, and was noticing difficulty in climbing stairs also. And he also noticed that his arms and legs were becoming thin. He had stretch marks over the abdomen, easy bruisability elsewhere on the skin, complained of headache without any visual disturbances, and intermittent back pain. He gave no history of any intake of steroids. So this is very important, because in our country we have people taking steroids in many different forms. They may be taking in the form of some powders and Ayurvedic preparations, or various sorts of preparations are taken by many of our patients. So we need to carefully look at this. And then he had history of tobacco intake, sleep disturbances, mood swings. He had a family history of hypertension and diabetes in his mother, but he had no other similar history in any of the family members. So this is his presentation. As you can see, very classical presentation with the abdominal distension, striae. He's got gynecomastia. He's got significant acanthosis, as you can make out, and his face is typically puffy, and you can clearly see that he has all these features of Cushing's, which are very obvious, and it doesn't require much of thinking to come to this conclusion. On examination, you see that he has got a BP of all these features which you have just seen. His BP is 180/90. His BMI is 50 kg per meter square. He's got bilateral gynecomastia. So basically, Cushing's syndrome comprises a large group of signs and symptoms that reflect prolonged and inappropriate high exposure of the tissues to glucocorticoids. Whereas the most common cause is iatrogenic from medically prescribed corticosteroids. It could be medically prescribed corticosteroids. It could be, it could even be steroids which are being used surreptitiously by patients, or it could be over-the-counter preparations used by many patients who have been prescribed steroids at one point of time, and then they continue using it because they find relief for joint pains, or whether it is for asthma or whatever it is. And however, endogenous Cushing's is relatively uncommon, if you look at the vast majority of patients who have exogenous cortisol use. So excess cortisol production, the biochemical hallmark of endogenous Cushing's, may be caused either by excess ACTH secretion from a pituitary source or from an ectopic source, as Dr. Nihal has shown several patients who had these ectopic ACTH syndromes, and he has discussed very elegantly the various presentations. Or it could be from an adrenal overproduction of cortisol. Now, if you look at population-based studies, probably we don't have very good data from India, but if you look at European population-based studies, the incidence reported is about 2 to 3 cases per million inhabitants per year. So that's the frequency with which you may be seeing endogenous Cushing syndromes. Cushing syndrome is clinically unmistakable when full-blown clinical spectrum of presentation is there. But however, diagnosis can be challenging when there are few features. We have some features which are more discriminatory than the others, include the purple striae, the plethora, the proximal muscle weakness, and bruising with no obvious trauma, and unexplained osteoporosis. So these are some things, because we may have many patients presenting with weight gain, with diabetes, diabetes which is difficult to manage, hypertension which is difficult to manage, and these also, they could be if you find these more discriminatory features, then you should certainly evaluate them for Cushing's. So the other features like obesity, depression, diabetes, hypertension, menstrual irregularities are more commonly seen. They are not very discriminatory for the presence of Cushing's. So this table lists out those features which are more discriminate for Cushing's: easy bruising, facial plethora, proximal myopathy, striae, especially if they are more than 1 centimeter wide. And in children, if there is weight gain with decreasing growth velocity, then that is a situation where we should evaluate for Cushing's. You could have many of these other features which are not very discriminatory. You may have a suspicion, but these are less discriminatory for Cushing's. So the evaluation of Cushing's, coming to the evaluation has to be stepwise evaluation. The first step has to be always, because as we discussed that exogenous steroid use is very common and that remains the commonest cause of Cushing's, and so therefore we should first look for that before we go ahead and look for confirmation of endogenous hypercortisolism, and then we need to differentiate between the different types of Cushing, that is whether it's a pituitary source of excess cortisol production, or whether it's an adrenal source. Pituitary source is common seen in about 70% of patients. 15% of patients have adrenal lesion, and 15% have ectopic ACTH secretion. And so localization is the next step that we need to do after we are able to differentiate, after we are able to confirm that it's endogenous, and then we differentiate between the different sites where it is. So the initial evaluation for confirmation, that is for excluding the exogenous steroid use, the best test is to do a 8 a.m. cortisol. Early in the morning you do a cortisol, and if the person is on exogenous steroids, then his cortisol levels will be suppressed, while if they are not suppressed, then it clearly indicates that there is then he needs to be evaluated for endogenous hypercortisolism. For the initial testing, the Endocrine Society guidelines recommend one of the following tests based on the suitability for every given patient. So it could either be a 24-hour urinary free cortisol, at least 2 measurements need to be done, or it could be a late night salivary cortisol. Again, we need to repeat the measurement on more than one occasion, a 1 mg overnight dexamethasone suppression test, or a longer low dose dexamethasone suppression test with where 2 milligrams of dexamethasone is given over 48 hours. So the 8 a.m. If you look at the overnight dexamethasone suppression test, It's in normal subjects. The rationale for this test is that in normal subjects, the administration of a supraphysiological dose of glucocorticoid results in suppression of ACTH and cortisol secretion. While in patients with Cushing's, of whatever cause, there is failure of suppression when the low dose of synthetic glucocorticoid dexamethasone are given. It's a practical screening test, and it should be done. It can be done in an outpatient setting. Doesn't require the patient to be admitted. And why is dexamethasone preferred? It's because the does not cross react with cortisol in the routinely employed assays. The procedure would be to give dexamethasone 1 milligrams between 11 p.m. to 12 a.m. Obtain the plasma cortisol at 8 a.m. in the next morning. The interpretation would be that normal subjects would be able to suppress the plasma cortisol to less than 1.8 microgram per deciliter. The outpatient overnight test has high sensitivity, almost 95% sensitivity, but it has a low specificity, and further investigation is often required. If you look at the standard low dose dexamethasone suppression test, this is where plasma cortisol is measured 48 hours after administering dexamethasone in dose of 0.5 mg every 6 hours, and this is done again early in the morning. And administration of dexamethasone begins at 9 a.m. You give it 9-3-9-3 schedule, or you could just do it as 12-6 and every 6 hours for 48 hours. Obtain a sample for serum cortisol at 6 o'clock when you're doing this 9-3-9-3 schedule, or it should be 3 hours after the last dose of dexamethasone that is given. Now, for pediatric patients, if you're looking at children or adolescents weighing more than 40 kgs, the initial adult protocol described above can be used, and the adult threshold for normal suppression can be used. For children weighing less than 40 kgs, then the dose is adjusted to 30 microgram per kg per day in divided doses. So, using a post-dexamethasone plasma cortisol concentration less than 1.8 as a cutoff, this test is reported to have a 97 to 100% true positive rate and a false positive rate of less than 1%. Therefore, it's more specific than the overnight dexamethasone suppression test. However, we need to keep a caution that there could be many pseudo-Cushing states where the levels may be in the range of 2 to 7 microgram per DL may be encountered, and these could be because of chronic alcohol abuse, or it could be because of metabolic syndrome in patients with PCOS, those who have depression, and those with morbid obesity. In all these situations, you can see levels between 2 to 7 microgram per DL. Hence, additional testing may be recommended in these individuals. So, to look at all the conditions where you can see the pseudo-Cushing's, it could also be seen in pregnancy, depression, alcohol dependence, glucocorticoid resistance, morbid obesity, poorly controlled diabetes mellitus. And there could be other situations where you may have pseudo-Cushing's without clinical features of Cushing's, and these are in patients with malnutrition, anorexia nervosa, intense chronic exercise, hypothalamic amenorrhea. In all these situations also you may have high cortisol levels which are not suppressible, but here again there are no clinical features of Cushing's, while these are the situations where you are seeing clinical features of Cushing's and you call them as pseudo-Cushing's. So what is to be done for that? You could use CRH after low dose dexamethasone suppression. This is helpful in distinguishing pseudo-Cushing state from Cushing syndrome. The rationale of this test is that this test is based on the fact that suppression of ACTH by dexamethasone is more profound in normal subjects and in those with pseudo-Cushing states, such that following proper suppression with dexamethasone, serum cortisol cannot be stimulated by CRH in these patients, but only in patients with Cushing syndrome it gets stimulated. So when you administer CRH after dexamethasone, only patients who have Cushing syndrome show a rise in the cortisol levels, which does not happen in any of the pseudo-Cushings or in patients who are normal. However, there could still be false positive results because of increased metabolic clearance of dexamethasone, which indicates that there is a failure of suppression, or rather the dexamethasone levels itself are not reached enough to suppress the endogenous cortisol, are not enough to suppress the cortisol levels, and this can happen with various drugs like rifampicin, phenytoin, carbamazepine, phenobarbital. High estrogen states like pregnancy and OCP use are some situations where this can be a problem. False negative results are also likely with particularly in patients with renal failure, where there's decreased clearance of dexamethasone. This can cause a exaggerated suppression because of dexamethasone, and that can give a false negative result. So in all these situations, if you simultaneously measure the plasma dexamethasone, it may be useful to detect these problems, and a value greater than 3.3 nanomole per liter as measured by LCMS appears to improve the accuracy of the test. So if you see that the dexamethasone level is more than 3.3, then it gives you assurance that you're probably not dealing with a false positive result. Now the other test that we can use is the 24-hour urinary free cortisol, and this is basically a time integrated assessment of cortisol secretion over 24-hour period. It measures the cortisol that is not bound to CBG, which is filtered by the kidneys unchanged. Therefore, unlike serum cortisol, which measures both the CBG bound and the free cortisol, urinary free cortisol is not affected by conditions and medications that alter the CBG levels. So this is for collecting the sample. The first urinary void sample is discarded like in any other collection, and the entire day's collection has to be done, and the next morning the void has to be done has to be collected, and it has to be refrigerated in between. And once the and the other important assessment is that appropriate assessment of the urine volume and urine creatinine levels also should be ensured to assess the adequacy of collection. Patient should be advised not to drink excessive amounts of fluid and to avoid use of any glucocorticoid preparations, including steroid-containing skin creams or hemorrhoid creams, etc., which could contain steroids. And at least 2 collections should also be performed, because in this situation also, because we need to avoid errors that can happen. And values exceeding 2 to 3 times the upper limit of normal is what we are looking for to indicate the presence of high fluid intake is a situation which can significantly increase the urinary free cortisol. Any physiological or pathological conditions that increase cortisol production also raise the urinary free cortisol. Therefore, in these conditions, a normal result is more reliable than an abnormal one. A falsely low urinary free cortisol can occur when the creatinine clearance falls less than 60 ml per minute, and urinary free cortisol levels fall linearly and with more severe renal failure. They can be normal in patients who has a cyclic disease, and also whose collection is not appropriate. Finally, it may be normal in some patients with mild Cushing's syndrome and in whom the salivary cortisol may be more useful. Coming to the midnight salivary cortisol, this has emerged as a very useful test. This is based on the circadian rhythm of cortisol secretion. The loss of circadian rhythm with absence of a late night cortisol nadir is a consistent biochemical abnormality in patients with Cushing's syndrome. The difference in physiological this difference in physiology forms the basis for a measurement of midnight cortisol, and or what is also called as a late night salivary cortisol, because now we are looking at the salivary cortisol rather than the serum cortisol, because serum cortisol requires the patient to be admitted and be in the hospital and in a peaceful setup. So therefore, we are now looking at the late night salivary cortisol, which has a good yield in terms of 92 to 100% sensitivity and a 93% again 93 to 100% specificity for the diagnosis of Cushing's. A sleeping midnight cortisol, we are looking at greater than 1.8 or more, or an awake value of greater than 7.5 increases the probability of Cushing's when the index of clinical suspicion is high. These are best done by using ELISA or assay performed by LCMS. A salivate is used for collecting this over 2 to 3 minutes. The patient chews the cotton swab and then puts it in a plastic tube which is stored at 2 to 8 degrees overnight in order to be processed the following morning. And late night salivary cortisol should also be performed twice, ideally in a row, to improve the sensitivity and specificity. Now when we come to once we have done these tests and we have seen that there is endogenous hypercortisolism, then we need to differentiate amongst the different forms of Cushing's syndrome and then look at localization. So for that we can do the plasma ACTH level, a high dose dexamethasone suppression test, a Crh stimulation test, and then for localization then you have the inferior petrosal sinus sampling. You can do the MRI with pituitary protocol, CT adrenals, and CT thorax or abdomen scintigraphy may be required as required. So if you look at the ACTH simulation, the ACTH is done to the ACTH a value of ACTH less than 5 picogram per ml is suggestive of ACTH independent secretion, while a value more than 15 is suggestive of ACTH dependent secretion, and a very high ACTH value is again in favor of ectopic ACTH secretion, as Dr. Nihal has covered, and he's shown in his presentation in his cases where the values have been in 600s and 200s, where you see such high values, then you are clearly looking at ectopic ACTH secretion. If you're looking at ACTH independent disease, then you are when it's less than 5, then you look at going for adrenal imaging. CT or MRI may be helpful in such situations. Particularly we are looking at CT scan in such situations, and adrenal venous sampling is may be required to lateralize the lesion, and then go ahead with you can then go ahead for surgical or medical management in such cases. Now, coming to the high dose dexamethasone separation test, the rationale for a high dose dexamethasone suppression is that Cushing's disease, the negative feedback control of ACTH is reset to a higher level than normal in Cushing's, and therefore cortisol levels do not suppress with the low dose dexamethasone but do so with a higher dose. And the original test, which was introduced by Little, was based on giving 2 milligrams of dexamethasone every 6 hours for 48 hours and demonstrating a fall in of greater than 50% in the urinary 17-hydroxycorticosteroids. Now in the modern test, what we are doing is we are doing the same thing, but we are looking at a 50% fall in the plasma cortisol from the basal value, which was done earlier, and that suggests a positive response. And this can be combined with and we have also discussed about the Crh stimulation test, which we have discussed earlier. The Crh test is helpful in confirming the doing the ACTH excess. The test involves intravenous injection of ovine or human sequence of Crh in a dose of 1 microgram per kg body weight or a single dose of 100 micrograms. The test can be performed in the morning or afternoon, and after a basal sampling Crh is administered, and blood samples for ACTH and cortisol are then taken every 15 minutes for 1 to 2 hours. The interpretation is that in normal subjects, Crh produces a rise in ACTH and cortisol of 15 to 20%. This response is exaggerated in patients with Cushing's disease, in which typically a rise of greater than 50% happens. ACTH rise of more than 50%, cortisol rise of more than 20% over the baseline values are seen. These responses are seldom seen in ectopic ACTH syndrome. As you can see in this on the right panel, you could see that the ACTH marked rise of ACTH is seen in Cushing's disease. Rise of cortisol also is seen, whereas in ectopic ACTH secreting lesions, you don't see a rise in the ACTH levels. The Crh stimulation test has a sensitivity and specificity of more than 90%. And we just discussed about the positive response. However, 10% of patients with Cushing's disease do not respond to Crh also. So this is a limitation that can be with the Crh stimulation test. So the inferior petrosal sinus sampling is probably a is probably the most robust test designed to distinguish Cushing's from ectopic ACTH syndrome, and because blood from each half of the pituitary drains into the ipsilateral inferior petrosal sinus, catheterization and venous sampling of both the sinuses simultaneously can distinguish a pituitary from an ectopic source of ACTH. So as we can see in this picture, simultaneous bilateral inferior petrosal sinus sampling plays a very crucial role in the diagnostic workup of Cushing's. It's the most accurate procedure in the differential diagnosis of hypercortisolism of pituitary versus ectopic, as compared with clinical and biochemical imaging analysis. Has a sensitivity of 88 to 100% and 67 to 100% specificity. So it's if you're looking at differentiating pituitary for ectopic, we are looking at a peripheral to central gradient of less than 1.4 is suggestive. Is seen is actually differentiating that. In contrast, the ratio is elevated to greater than 2 in Cushing's disease. So if you have a pituitary Cushing's, it's more than 2. If you're looking at ectopic, then it is less than 1.4:1. And since the ACTH secretion is pulsatile, it is useful to take measurements before and after, at intervals of 2, 5 and 15 minutes after intravenous injection of the ACTH, of the CRH. Using this approach, an ACTH petrosal sinus peripheral ratio, that is petrosal sinus versus peripheral ratio of greater than 3 after CRH administration, has a sensitivity of 95% and a specificity of nearly 100% for diagnosing Cushing's disease. And for those, where we are going towards ectopic, we are having indicators of ectopic Cushing's. Then we have just discussed about the evaluation of these. But for lateralization, when you're looking at Cushing's, when you are looking at a pituitary Cushing's, then you're looking at IPSS for lateralization. It may also have value in lateralization of the pituitary tumor in a patient in whom imaging techniques have failed to demonstrate a microadenoma. However, some centers have found this procedure to be of little value because in predicting the localization, tumor localization, because most of the tumors are central and can drain into both sinuses, and so the current evidence probably is suggesting that it's unwise to base the surgical procedure on the results of IPSS alone, and we need to look at the MRI picture also. And IPSS is technically demanding, and it has been associated with the complications, referred oral pain, thrombosis, and should be performed only in experienced tertiary care centers. All centers do not have the facility for doing IPSS. The two main indications we can say is lack of adequate separation after high dose dexamethasone or a CRH response, and the absence of microadenoma, absence of a pituitary lesion more than 6 millimeters. If it's a more than 6 millimeters lesion on the pituitary scanning, probably you don't require a IPSS sampling to be done. In order to correctly predict the source of excess ACTH, blood samples must be taken from both inferior petrosal sinuses in order to avoid the risk of incorrect identification of the site containing the higher ACTH concentration, therefore make a erroneous diagnosis of ectopic. Simultaneous sampling of both inferior petrosal sinuses overcomes the risk of sampling blood during different episodes of ACTH secretion and allows comparison between the sides of the pituitary in an attempt to localize the ACTH secreting lesion within the gland. The caveats are that patients with active phase of cyclical hypocortisolism or previous medication.
You can go a little faster. We are running short of time. Thank you.
I'll just conclude by showing the indications. It's reserved for patients with clinical biochemical evidence of Cushing's disease and negative or equivocal MRI findings, equivocal response to hormone tests, or in cases of discrepancies between biochemical and imaging findings after previous unsuccessful pituitary surgery to ensure that diagnosis of Cushing's disease is correct. So this table pretty well illustrates the approach that we have just said. I would show this, which summarizes this, saying that Cushing syndrome clinically biochemically confirmed. Look at the ACTH values. If they are suppressed, then you look at the CT of go towards adrenal imaging. If it is ACTH is more than 15, then we're looking at or ACTH is then we're looking at ACTH dependent disease. 50% cortisol suppression following high dose dexamethasone, more than 50% increased serum cortisol post CRH stimulation, normal potassium and bicarbonate, positive MRI scan of pituitary. Then if these are true, then we go for transsphenoidal surgery. If the test is inconclusive, then we require to do a IPSS sampling, and no ACTH gradient, ectopic ACTH syndrome, then appropriate indications in radiology for the ectopic ACTH secretion. So this is how we should go about. And coming back to our case, this patient had a 8 AM cortisol done. It was found to be 35, clearly suggesting that it is it rules out the exogenous exposure. Then he went for a 24-hour urinary free cortisol, which was 780 microgram per DL, more than almost 2 times elevated. LDDST was 20.25. ACTH value was 41 picograms per ml, and his HDDST value was also done, which was 8.9, showing a more than 50% suppression, indicating that it was a pituitary source. Imaging of the pituitary, we found a 6.6 into 6.8 millimeter pituitary lesion, and which was well defined altered signals intensity with non-enhancing in dynamic sequence. So this indicated indicates that it is a pituitary source, and he is waiting to go for surgery now. So with that, I'll conclude, and I'll be happy to answer.
Thank you, Professor Rakesh, for the nice overview of lab diagnosis of Cushing's. I think the take-home messages would be that in an obvious evident Cushing's, like the case which Professor Rakesh has shown, the diagnosis is easy, and the lab tests confirm the clinical diagnosis. But however, in mild cases of hypercortisolism, we need a sensitive test with a good specificity, like the overnight dexamethasone suppression test. So most commonly, we all use the overnight dexamethasone suppression test. However, maybe in smaller places, we do not have access to the late night salivary cortisol, and the midnight cortisol is cumbersome. The urinary free cortisol is helpful in certain situations like pregnancy and children. So as far as screening is concerned, we still stick on to the ONDST. However, the caveats need to be kept in mind, like especially the false positives. And for the differential diagnosis, I think ACTH with its good assay is a reasonably good test, but however, the overlap remains between pituitary as well as adrenal origin. And I think most important message would be that the collection of ACTH sample should be taken into consideration. So I think with these comments, I do not have any experience with IPSS. I would request Dr. Sriram and Professor Mala to give their comments further.
If time permits, I think Dr. Mala has mentioned Dr. Ali wants to ask a question. We can allow one question, I think, for out of time.
Oh, thank you so much from Canada, Dr. Rakesh. That was a wonderful presentation. I just wanted to ask a couple of questions. It's very difficult to get CRH, at least in our center in Canada. So we're using a lot more DDAVP because it shares the same receptor pathway as for the ACTH receptors. Number one, I just wanted to see what your experience is there. And number two, we're using prolactin in the setting of IPSS to make sure we get good cannulation, especially in the younger interventional radiologists who might not have that experience. I just wanted to ask that. And my other point is, whenever I actually ask my patients to do these tests for cortisol excess, I make sure they don't do it on a day when they're sick with a febrile illness or any acute illness, because you're going to get a slightly false positive. Just some comments there and some questions. Thank you.
Yeah, thank you, Dr. Ali. I think those comments are very well taken, and as you said about the sick days on which you would get a false positive cortisol excess, and also about the availability of DDAVP, which we prefer to use now rather than the CRH.
Just a small comment there. Even DDAVP as an injection is not available in our setup. So we, in the recent past, were lucky to do IPSS on a couple of patients, and we used only the lysine vasopressin, which is available as
AVP.
So if there are no more comments, I thank Dr. Rakesh for a very good overview of the entire Cushing's and all the nitty-gritties of all the presentations of the pituitary and the adrenal Cushing's, and of course touched upon ectopic and the IPSS. Thank you very much, Rakesh. And we go to the next talk, which is by Dr. Sriram Mahadevan. So please stay there. I introduced Dr. Vaishali. Dr. Maithili is already introduced. Dr. Vaishali, one second. Share her presentation slide. Dr. Vaishali is Assistant Professor in Endocrinology in Sassoon General Hospital and BJMC, Pune. She's Consultant and Head at Dinanath Mangeshkar Hospital and Clinic in Pune. And she's attended huge number of webinars and CMEs as faculty. She itself has her own CMEs that she conducts every Sunday, I think every one Sunday in a month, and it's well attended. And she has excellent topics which she has. She's authored few chapters in 5 books, and she's PI in many studies. Her special interest, which I like to mention, and she's very passionate about, is mind-body medicine. And she's also conducted few programs in that, and she's organized Synapse, and she's also a member of a lot of committees and organizations. So over to Dr. Vaishali and Dr. Maithili to take the session forward, and Dr. Sriram to talk about hypercalcemia in rare situations, rare causes.
I think we'll request Professor Sriram to start the session, to start his talk.
Thank you, madam. Thanks. I think it has become customary now to ask. I think my screen is visible, and
yes, sir.
Yes.
AV problems. Okay. My talk, I was surprised I confirmed with Dr. Mala that they had written rare causes of hypercalcemia. Then I came to know that the audience for this sessions will be predominantly endocrinologists, and I think I'm shining torchlight to the sun, but still I'll try my best to touch upon the topic itself. Is fortunately rare. So rarer causes is what they have given specifically, and I'm thankful that the JCEM last month edition is carrying a very important review on this, and I will share with you whatever recently I have read on this, and share initially 3-4 cases which we happen to see, which actually picked a lot of brains of ours as well as other departments in the recent past. So with that, rarer causes hypercalcemia. Before going into it, we all know that calcium has a exquisitely sensitive relationship with the parathormone as well as the vitamin D metabolites, especially the active vitamin D. And it is maintained within a very narrow range. In a good lab, if you assay in a given person over a 24-hour period, it wouldn't change even by 0.5 to 0.8 milligram per day. So to that extent, it is very narrowly maintained by the parathormone sensitive feedback. And we all know that whenever somebody we evaluate for elevated calcium for whatever reason they have come, we need to, in our setup, we don't do ionized calcium routinely, because the ionized calcium assay itself, obviously cost is also a reason in most of the setups in India. And secondly, the calibration should have been done properly. The ABG machines, invariably today, the longish printout gives calcium also along with others, but it is preferable to avoid that because it is not calibrated in most of the setups. So we do only total calcium corrected for albumin. That is a time-tested method, robustly, performing well in most of the setups. So in this background, if somebody's hypercalcemia is confirmed, which we all know that usually if hypercalcemia is significant, it will be clearly 1 milligram at least more than the upper limit of that lab. That is the definition usually we use for primary hyperparathyroidism, but fairly it holds good for several other situations. But in the previous talk, when Dr. Rakesh Sahai was mentioning about Cushing, and Dr. Maithili Madam nicely mentioned that classic cases, we have no doubts. The calcium will be very high, 14, 15, and especially if they are dehydrated, it will be still higher. So there is no problem. The problem comes only in the minor cases. But today's discussion is not on primary hyperparathyroidism, where you may, on a routine testing, pick up mild elevations. So once you have confirmed hypercalcemia, on the right side of my slide, I have put, like in hyponatremia, we used to discuss pseudo-hyponatremia. Here, there are some rare situations where pseudo-hypercalcemia. When I read this, I was surprised why this reviewer has written this. Last month, I had seen one affording patient, robustly healthy people checking calcium. Calcium was actually 11.8. Both the sister and brother came for the same problem. Then I found that their albumin was 5.3. What was the reason? So this is a very simple thing in the lab. First check the albumin whenever you see the calcium. There are rare situations where platelets in essential thrombocythemia-like condition may extrude calcium and cause a false elevation. Similarly, in myeloma, the M protein antibodies can sometimes attach to calcium and interfere in the total calcium assay. See, these are all rare causes of pseudo-hypercalcemia. Otherwise, most of the hypercalcemia, or when corrected for albumin if high, the first step we do is to measure an intact parathormone assay. Again, like ACTH, parathormone is a very labile, fragile, and the sensitivity, the half-life is very short. So we should assay as early as possible. And if it is clearly elevated above the upper limits of the lab, then we diagnose straightforward primary hyperparathyroidism. If it is clearly suppressed, when I mean suppressed, it should be nearly undetectable or less than 10. Then it means the hypercalcemia is not parathormone mediated. And it is invariably due to some malignancy or some other causes. So only two causes of hypercalcemia most often we encounter as clinicians. One is primary hyperparathyroidism, which is the most common cause of hypercalcemia, both in the outpatient setting and very often in the secondary level care setting. But in a tertiary care setup or in ICU or in a sick patient, when somebody has hypercalcemia, the most common cause, and especially if the PTH is suppressed, it is malignancy. So if you rule out primary hyperparathyroidism and malignancy, then the list of hypercalcemia still is a significant bit, but that is what we are going to discuss today. These two causes are the most common. In a typical OP setup, if you diagnose hypercalcemia, PHPT is common. If in an admitted, relatively sick patient, it is malignancy. So today, in the next 15 minutes, I will be discussing only not about these two conditions, but other conditions which are rarely associated with hypercalcemia, not easily picked up by these two things. Then comes, once you don't have the PTH, elevated, then you are diagnosing non-PTH mediated hypercalcemia. If you have the facility and then PTH-RP is not a bad idea to check, but we don't do it most often, especially because the malignancy which is causing the hypercalcemia will show up itself. In a typical, squamous cell carcinoma of the lung, I don't think we need to check a PTH-RP and, to diagnose malignancy-related hypercalcemia. Similarly, if you diagnose myeloma, where PTH-RP is not the cause, but still you don't need to do all this. But for an algorithm approach to complete the list, these are all written here. And the algorithm proceeds further, saying that if PTH-RP is elevated, then a tumor which is secreting PTH-RP, which is usually a truncated form of PTH with the active part of the PTH acting on the bones and causing hypercalcemia is the usual cause. If PTH-RP is not elevated, then it is not PTH or PTH-RP mediated. Then the active vitamin D is most likely the etiology. Again here, astute clinical examination and good review of the history will many times give you clues for some of the conditions which are mentioned here, like granulomatous diseases, tuberculosis, sarcoidosis. Other investigations will give you the clue. And if 25-hydroxyvitamin D itself is elevated significantly, which I'll be mentioning in an hour for cases we recently happened to see, vitamin D intoxication in this era of overzealous replacement It is not rare to have a given patient to have this condition. If these are all ruled out, then you have still malignancy as a cause, because the first step itself is actually PTH suppressed myeloma. Common things are common. And as the undergraduate medical college teaching goes, you diagnose a rare disease, you'll be rarely correct. That has to be remembered when we are discussing the next 15 minutes on the rare conditions. In this background, I will go through a couple of cases before going and giving you the list of rarer conditions from the recent review. This was one of the recent case, I think 6 months or 1 year back, we happened to see. This is usually your routine follow-up in an endocrine clinic. She was not under our follow-up. She came to us for the first time with a history of follicular variant papillary carcinoma, operated 12 years back with our total thyroidectomy, and she has received a couple of doses of radioiodine. As usual in many of our setups, the reports are lost. We don't have the exact details, but this is the history given. So as you know, in any neck surgery in a thyroidectomy patient, when they come to a typical endocrine setup, we usually check calcium. I actually check calcium to rule out actually hypopara, even though she is not symptomatic. That is a routine. We check for chostaxine and trosusine routinely in all the thyroidectomy patients, even though they may have near normal values. So I was surprised to see a hypercalcemia in this patient, and she's walking into the clinic with the neck surgery in the background. So by Occam's rule, we all know that even in a patient, and that too is a follicular variant where there could have been a skeletal metastasis, which many times is asymptomatic and they may not come with the symptom, you should actually explain it by that. So we approached it, as you know, hypercalcemia. First step is to do PTH assay. You see the PTH is clearly elevated. I was expecting that she will have hypopara, but on the contrast, I got a report of hypercalcemia with an elevated PTH, clearly saying that she has now a primary hyperparathyroidism. It was confirmed to be a left parathyroid adenoma and later operated. I mean, this is the usual story. I mean, why did I present this here? Just to give a clear, and mind you, thyrotoxicosis can also cause hypercalcemia, but not the iatrogenic toxicosis, which we usually see. I mean, in the sense, iatrogenic means exogenous damage. Here we are giving suppressive doses of thyroxine, as you know, in a typical cancer, thyroid, well-differentiated cancer follow-up. So that is not usually associated, but Graves' disease, severe hyperthyroidism is also sometimes associated with calcification. I mean, hypercalcemia. So the point here to be noted that even in a patient with an underlying malignancy, if the parathormone is elevated with hypercalcemia, you should diagnose only primary hyperparathyroidism. It is extremely rare, even though for today's discussion in the next few minutes, we will be mentioning some of these. For a tumor to secrete parathormone is extremely rare. There are case reports and there are only case reports. That is the point here. So we should not go with the impression that that would be something else. So even in a neck surgery patient, even in a thyroid cancer follow-up, this patient turned out to be a primary hyperparathyroid. This is number one. Number two, this was even more slightly intriguing. This patient actually got admitted under our nephrology department with a 45-year-old male, fortunately reasonably affording patient who came with actually fever, chills, generalized aches and pains for more than a month. Otherwise healthy person with no significant comorbidities. The only issue is he had COVID, which he recovered from in April this year with a prolonged stay in another hospital in Andhra Pradesh. And from here he came to our hospital. And he had acute kidney injury with significant hypercalcemia, 14.6. And he also had anemia and a urinary tract infection. All these are not fitting. In a young male, most of these are unexplainable, as you know. I'm not going to the general medicine things. You see here, this patient had hypercalcemia with suppressed PTH. Clear cut, okay. Even though he is a young fellow relatively, malignancy should be your first thought. But we do the bone mineral profile together in many of our patients. So we get the 25D immediately, and this value was very high, more than 100. We didn't do in dilution, but the phosphorus was also normal in spite of acute kidney injury. He required dialysis for a couple of times, and his alphos was normal, PTH suppressed, and this guy had elevated both 25 and 125D, all done routinely. And CT chest, as you know, is done as part of corona screening, and other causes of malignancy or other non-PTH mediated hypercalcemia were done. So even PET CT was done, there was no uptake. This is an easy way of ruling out any inflammatory or other conditions. Okay. So on further probing, this was the interesting history this guy gave. He actually was suggested by one of his cousins, who is actually a nursing staff in another major government hospital in North India. She told that you take vitamin D for the post-COVID fatigue. And he took the injection, vitamin D. You'll be surprised to, I have not seen this in any patient before. We have seen orthopedicians misusing or overusing vitamin D injections, repeatedly giving weekly or daily. But what this man has taken is our usual, cholecalciferol injection, 6 lakh units. He has broken 3-4 ampules daily, and he has drunk it along with milk or curd for several days. Exactly, he didn't mention. So you can imagine the amount of vitamin D he has taken over a short span of less than a month. And he's still under our follow-up. Calcium has settled. We have given denosumab in view of renal insufficiency. We have put him on a stiff dose of prednisolone. Calcium has settled, but the vitamin D, as you know, is fat soluble. It is there in his body for a long time. It will take several half-lives. 25D half-life is at least 3 weeks. So I think this man will take several months for him to come out of this whole episode. So I think this is a learning lesson that we have to dig into the history. What is very important in this case is, even though he was admitted under our nephrology department, we were also seeing him daily. They were also seeing. He didn't come out with this history. We had to ask him again and again. We had to call the people. After several sessions only, he came out that he took this vitamin D at this dose. Otherwise, such high doses, we went ahead with PET-CT to find out a granulomatous in the lesion. But sometimes our patients also, they test our patients, and we have to really dig into. This was one challenging case we saw recently. The next one is even more intriguing. This was another rarer cause we saw again recently. 45-year male, again, known case of CKD. He was advised maintenance hemodialysis, which he is undergoing. But however, as you know, many of our less affording patients do it inadequately. He is taking it only maybe twice a week against the usual suggested 3 times a week. And he came with altered sensorium and decreased output, which was expected at this, dialysis with a creatinine of more than 10. And you can see here again hypercalcemia. But in spite of kidney insufficiency of that severe nature with inadequate dialysis, his phosphorus was on the lower side. We expect PTH to be high in a CKD, and it was suppressed, and 25-hydroxyvitamin D on the near normal angle. We rarely see this in a CKD patient. And again, you see here, the characteristic point is the bicarbonate, which is nearly on the alkalotic range. We don't expect any of this in CKD. And probing again into the history, why he could have had hypercalcemia. Again, as you know, malignancy will strike you, but CKD, with all the recent events, told us that it might not be, and we should not already a less affording patient. We can't afford too much on the malignancy perspective. Again, digging the history, he was taking too much of calcium preparations, overzealously treated, and he was taking the common 500 milligram calcium tablets, almost 3 grams per day. I don't know who suggested that. He was under a good nephrology follow-up from another hospital, but still he was taking not less than 2 to 3 grams per day in the last 3 months. And reviewing literature, we found that in these kind of patients, when there is alkalosis along with hypercalcemia, the condition called milk alkali syndrome is well described in the past when you were treating the peptic ulcer disease with alkalotic preparations, the usual agents which we all use, the the bicarbonate-based preparations. Calcium carbonate can be absorbed excessively in some patients, and there is a recent trend that overzealous use of calcium preparations in a given setting, along with alkalosis, you could have calcium alkali syndrome or the hitherto milk alkali syndrome in some of the patients. And after stopping the calcium preparations and intensifying dialysis, he normalized and he is doing well. Last case before I go into the review is our colleagues from PGH Chandigarh. This is a very rare situation of hypercalcemia, clear-cut diagnosed in a 25-year-old male with recurrent pancreatitis and hypercalcemia, but low normal PTH. So I think there is a lot of information from the PHPT registry from Dr. Sanjay Badada sir and all his colleagues that if you have gallstones, pancreatitis, and renal stones, etc., the threshold for diagnosing primary hyperpara should be very high, or very low. Threshold means very low. So you should diagnose even if the PTH is normal. That's to that extent they were clear in this case that we are missing out in being very young, malignancy being almost unlikely. And what was diagnosed here is that even though he had low parathormone, he was diagnosed with a very rare condition. Parathyroid adenoma was diagnosed. He was operated, and the PTH low was probably due to any of these causes. I think the postgraduates who may be listening to this talk may make a note that there are some situations where even in a PHPT, the PTH may not go high to the level we can easily diagnose, even with the common assays we are using now. In our hospitals, we are using the chemiluminescence assay, but in some of the hospitals where IRMA may be there, you could have a hook effect, which is usually heard only with prolactin, but very rarely in parathormone you can have. Hypomagnesemia could blunt the elevation in PTH in a given patient. And you see here, sarcoidosis, vitamin D toxin, all these are other conditions where, along with hyperparathyroidism, it could suppress. So all these should be maintained. Most common cause of a lowish PTH in our setup is the lab not taking the sample or reaching the sample takes a longer time to reach. I think we have to maintain the cold chain well, otherwise these kind of rarer cases will be commonly diagnosed. And as I said before, we should go about only common things are common. So this is that review which I was mentioning. The listeners, especially the postgraduates in endocrinology, can note this, a very good review. John Belezekian and his group, they have done for the second time. After 2005, they are writing the same review again in the same journal. The main idea of this review is to give all the collections of rare case reports, because it is very, very rare, like that milk alkali which I mentioned, or another rare patient which I'll be mentioning now. They are all very rare that you will not have a big series from one single center. So, and it's not possible to do randomized things and all here to prove anything. So we have to know that such cases are being reported, and that's the main idea of a collection of all this. So quickly in the next 5 minutes, I'll just mention, it'll be boring if I read out all the causes, but you see here, if you have normal or suppressed PTH in a patient with clear-cut hypercalcemia, evaluate extensively for malignancy. If you suspect that vitamin D related, like our patient who was overzealously treating himself with the vitamin D, you see the number of conditions which can cause 1-alpha hydroxylase expression and vitamin D treatment. You see here, number of ones, including foreign body injections, particles like a breast cancer, breast transplant patient, PMMA very commonly used in our orthopedic colleagues, injections. So please, these kind of reviews are helping us to understand that rarer causes to be kept in mind, but use your common clinical judgment. Interesting point I read here is there could be non-granulomatous conditions also which can express 1-alpha hydroxylase. This is in the last decade, nephrogenic fibrosing dermatosis is a condition uniquely seen in CKD patients on dialysis who undergo MRI scan. The gadolinium-based scan can cause an inflammatory reaction in the skin causing this condition, and that may rarely cause. And I also read, I am reminded of my professor, Dr. Bansali, who will ask so many, tricky questions on the bedside. Acromegaly per se can cause 1-alpha hydroxylase elevation or, increased activity, it seems. Usually the dictum in bedside teaching is, in acromegaly, if you have hypercalcemia, you should suspect MEN1. But one more reason you can possibly notice, you can have a direct action of GH on 1-alpha activity, rarely, and after treating acromegaly, the hypercalcemia settles. And there are newer agents which are CAMP analogs. As you know, CAMP is the second messenger for PTH, and that can cause hypercalcemia in a rare situation. The last point, it has a lot of research potential, is the 24-hydroxylase, which is the inactivating enzyme for 125D. So the 125, instead of the 25D activating to 125, it can get inactivated to 2425. If there is an inactivating mutation of the 24-25 hydroxylase, then you could have hypercalcemia because of overproduction of 125. The reverse can also happen. In a given patient, if there is an activating mutation, you will not have vitamin D being properly activated to 125. So this is a rare things which we can sometimes rarely encounter in our setup. I already mentioned, in a given classic malignancy is diagnosed, then PTHRP need not be measured. But if in a tricky patient, like there are benign conditions like uterine leiomyomas, etc., can also sometimes secrete. And one more thing I learned today in the rare presentation of even pheochromocytoma in several situations in case reports causing PTHRP and hypercalcemia. I think these have to be remembered, and rarely in pregnancy lactation. One important point in pregnancy lactation is that pregnancy and lactation are two conditions where the 1-alpha hydroxylase activity is very high, both in the mammary tissue and in the placenta. So even in a hypoparathyroid patient, they usually do not require the active vitamin D at high doses, especially in the latter half of pregnancy. So that is a protective mechanism nature has given the mother to restore her calcium homeostasis during pregnancy and lactation. And usually there is no bone loss after the lactation is over. And excess calcium intake, I have already mentioned one of our patients in a renal failure setting. There are reports of poisoning. There are reports of even, you see the heat pack ingestion, calcium chloride being, I think that there are some psychiatric patients who can drink anything. I think these things we have to remember that there could be some rare situations, and do not leave any stone unturned in a given patient with an atypical presentation of hypercalcemia. That's what I can gather from this kind of thing. This is extremely rare. All the list here are, as I already mentioned, ectopic PTH secretion is only case reports. They are only isolated case reports of most of these, except probably ovarian cancer and couple of lung cancer causing PTH secretion. And it's so difficult to confirm. And it's not just the immunostaining. You have to show even the mRNA expression for PTH. And again, pheochromocytoma is coming in this list. So that is an endocrine twist here that we should remember. And papillary thyroid cancer. These are all things which we may, as a, it's like an endocrine twist here. We can remember rarely that this can happen. Concurrent PTH and PTHRP secretion is also reported in certain rare conditions. I am not going to read out, but as I mentioned, this whole rare causes of hypercalcemia is a compilation of all available, even isolated anecdotal reports. That's the whole idea. Drug-induced, we all know how lithium and thiazides are known to upset the set point of PTH and calcium, and hypercalcemia is a known complication of them. But however, you see here, omeprazole, theophylline toxicity, growth hormone therapy, these are all rare causes. Hepatitis B, I think these are all extremely rare case reports, but mentioning in a August forum here. In spite of all this, the authors mention about unknown mechanisms in several conditions, which include infectious and inflammatory conditions. So in general, any inflammation, it need not be granulomatous, may sometimes alter the 1-alpha hydroxylase activity. And this 1-alpha hydroxylase is again exemplifying how vitamin D is taken up by different tissues differently as per their need. It is not like the PTH alone systemically and in an endocrine manner controls. The local tissue effects and paracrine effects and availability intracellularly of 1-alpha hydroxylase, not only in the kidney, but in several other tissues, is what we learned from all these kind of rare case reports. In children, I just wanted to share that again, hyperpara is the most common. If you have high PTH, we happen to be part of 4 cases we had in the last 2 decades. We have seen of neonatal severe hyperparathyroidism. Fortunately, one child died, but all the other 3 are managed very well under follow-up. Extremely high calcium levels we saw in 2 of these children. 28 and 29, it is incompatible with an adult to have hypercalcemia like that, but neonates tolerate hypercalcemia well. As you know, the fetus in the 3rd trimester has in a severe hypercalcemic environment. So post-op, these children at diagnosis, this is because in one of the major neonatal centers, this is diagnosed incidentally, not that they came with person. So these are also several odd points in these presentations. And in one of the cases, I had used Cinacalcet for nearly 1 year in that child. And incidentally, it worked to some extent. At least the child did not require admissions in the hospital. We did not have a good endocrine surgeon to operate in the first decade. And fortunately, our colleague, Dr. Dalapati, after good training, he came and he operated on all the 4. And today, all these patients are doing well. This is an extremely rare case, so I put it here. And other causes of hypercalcemia in childhood are, either heritable conditions or acquired causes. In the heritable, we all know Williams syndrome, very common. The mechanisms are not known. This Hartnup disease or tryptophan-related things, incontinence, these are all rare things. Soto syndrome, there is gigantism, we know. So these are all rare conditions. I think obviously in today's technology world, any such rare things you will put up in the net and you'll come up with all this. And on treatment of our hypophosphatemic rickets children, you can have overzealous treatment, can have hypercalcemia. That is more common. Other conditions described here are somewhat mechanistically similar to the adult cases here. So in summary, we all know hypercalcemia in endocrine practice is not rare. We see it not that rare, especially if you are in a tertiary care or secondary care setup. The etiological understanding is important because management varies. PTH assay is the first step we do, and other metabolites of vitamin D or rarely PTHRP, you can use your clinical judgment. If these two conditions, namely primary hyperparathyroidism and malignancy, are not obvious in your case, then I think you have to open all your antenna and keep your options, ears, eyes open, and take a good history again, go into all the clinical and investigational clues, and try to solve your case individually. And you will be rewarding, it may be rewarding at the end that the hypercalcemia will settle well. Thank you very much for your kind attention.
Thank you, Sriram, for the very nice input on the rarer causes of hypercalcemia. As far as your first case is concerned, I think personally I had a similar experience of a papillary carcinoma of thyroid and a parathyroid adenoma. And I think the second case is an eye-opener to every one of us in this COVID era and vitamin D, so much of vitamin D intake. This is really an eye-opener. Thank you. One question is that should we stop medications like lithium and thiazides? You were mentioning about pseudo-hypercalcemia. So should we stop these medicines before estimating serum calcium?
Shall I answer that now?
Yeah, please.
The pseudo-hypercalcemia is not due to lithium or thiazides.
I know. So I was...
That is true hypercalcemia.
Yeah.
That is because of, as you know, the set point is, it will behave like a primary hyperparathyroidism. Yes. We have to stop thiazides and lithium lithium you cannot stop. We have to ask the psychiatrist whether it can be done. And that's a tricky thing there. But generally, you have to stop and reassess. And many times we have seen after you stop the thiazides, the calcium will normalize in general. Okay. And pseudo-hypercalcemia, I put it because I read in this recent.
Yes.
That is. Yeah,
I understood. Similar to that, I was. Yeah. Thank you.
Yeah, Dr. Sriram, that was an extensive review. I think that one important point that you made for the students was that the rare cause of hypercalcemia is rarest. So I think that is a very important take home for all of us. And I've learned it through my experience also. I can share 2 cases of hypercalcemia where I've tried to look out for one patient presented with classical primary hyperpara, 45-year-old woman. Her MEBs were negative done subsequently every year, and hypercalcemia persisted. We were treating her with medical line of therapy. Eventually, when 4D CT came to our institute, that time it was found that had a very small 4 millimeter to 5 millimeter parathyroid adenoma. So I think it is still worthwhile investigating into the depth and finding the cause for PHPT. That was what we learned with that. And second case was very interesting. She was referred to me, 60-year-old female referred for acute renal failure due to nephropathy. That was hypercalcemic nephropathy. And she had a very high PTH. And in view of that, they thought of a parathyroid adenoma and referred to me. But this patient had a acute renal dysfunction, so referred to nephrologist, eventually found to have myeloma. So she had myeloma kidney with secondary hyperpara. No, MEB was negative. And she had hypercalcemia due to myeloma. So what I learned here is that 2 rare causes can come together in one patient. And we need to remember that hypercalcemia can be a dual sort of a manifestation of 2 different diseases in the same person, especially sarcoidosis in a patient with SLE or something of that kind can be a combination sort of disease. So I think a very good overview and a good learning for all of us. Thank you so much. Yeah.
Thank you.
I have a few comments to make. Okay.
Yeah.
Go ahead.
And number 1 was the pseudo-hypercalcemia. Say in multiple myeloma, you suspect it when you find calcium of 17, 18 and the patient is completely normal. So that's how you actually suspect. Number 2, when you have a high albumin, normally what we used to do was we correct it when it is low. But then when you have a high, that's one place where you do an ionized calcium. So that's what was the recommendation previously. Okay, thirdly, for vitamin D intoxication, People have tried ketoconazole and chloroquine also as a therapy. And that CKD patient, I think we must also keep in mind tertiary hyperpara also. That's another thing which we'll have to keep. And in lithium, Dr. Maithili brought in, it may not be reversible if you have been using it for more than 10 years. It could continue. If it is a short duration, then only it's reversible. Say maybe less than 5 years or 3 years, no, then it's reversible. And lastly, the 24-25 hydroxylase. In fact, that mutations have been actually, people have tried blocking that to treat hypophosphatemic rickets actually.
One more thing I deliberately didn't mention is this abuse of 125D preparations. India is the capital of calcium preparations with active vitamin D, and that is in elderly people a very common cause of hypercalcemia, hypercalciuria, both. I think that's an iatrogenic thing. I think we can go on and on as endocrinologists discussing all these cases on our routine practice. Thank you, sir. Thanks for it.
Thank you. Thank you, Dr. Mala.
Dr. Shriram, it's Ali. Can I make a comment?
Sure.
Okay? I think one of the really important points that you made, Dr. Shriram, is the role of the phosphate. I always tell my non-endocrine peers and my residents that the phosphate is a cheap human being's PTH. It comes back very, very fast. It can give you a lot of clues, and your red flag should really go up, like you mentioned, when someone though you don't have a PTH, but someone has chronic kidney disease, but the phosphate is low, because you'd expect, especially in CKD, the phosphate should be high. So I think that's a really, really important teaching point that we really have to get across to our learners. And at the end of the day, that's going to guide you, especially if you don't have that PTH right in front of you right away for further investigations.
Thank you.
Agreed.
Thank you, Dr. Ali. And we go to the next session if the chairpersons are okay. So I thank Dr. Shriram and Dr. Vaishali and Maithili for this wonderful session and a very nice overview and I think very important points for the young endocrinologists. I ask Vaishali and Shriram to stay back. And we have the next speaker, Dr. Ali Prabhatani. He's from McMaster University, a very good friend of the last 20 years. And I would request the chairpersons to introduce him. I'm sharing his CV.
Dr. Vaishali, you can take over.
Yeah. Okay.
Yes.
It's my pleasure to introduce Dr. Ali Prabhatani. He is an internist and endocrinologist at McMaster University and full professor of medicine. He is the founder and director of the Global Health Program and the Endocrinology and Metabolism Residency Training Program. He is also Deputy Global Health Partnerships Aga Khan Health Services, Aga Khan Health Board of Canada. He is actively involved in teaching, advocacy work, clinical work, research, and administration. Many of these are voluntary basis locally and globally. And he is currently the Cancer Care Ontario Thyroid Ultrasound Reporting Group Expert Committee. And he is a part of numerous guidelines and has been a chair of the Endocrine Hypertension Group, Clinical Practice Guidelines of Hypertension Canada. He's consultant for South Asian Diabetes Chapter for Diabetes Canada. He's received the Ontario Voluntary Service Award and the Medical Humanitarian Service Award, the McMaster Global Impact Award, the OMA Presidential Award, and Outstanding Healthcare Professional. I think numerous awards to his credit. And we are very delighted to have you here today and hoping to listening to you. Over to you, Doctor.
Thank you, Dr. Vaishali. Can I share my screen?
Yes, please.
Okay. Can everyone hear me okay?
Yes, we can hear you. Go ahead.
Great. First of all, I wanted to wish everyone a very happy Diwali from Canada to my brothers and sisters in India. And I want to really thank Dr. Mala, who's a close friend. And I was a young endocrinologist when I first met her 20 years ago in Bangalore. And it's been so long, time's gone so quickly. But it's a pleasure and honor to be here in front of esteemed colleagues. And I just wanted to say the presentations have been outstanding, of very high caliber. And so I'm honored to be part of this group today. And I'm actually going to switch from a sugary talk to more of a salty talk. We've been dealing with cortisol. So I'm going to go from sweet to salty and share some information. I thought I'd make this in a practical manner for learners and for endocrinologists, make it applicable to your patients in an evidence-based manner as much as we have right now in this area. and make sure we all learn something at the end of the day. These are my disclosures. I have nothing profit related to this presentation today. So this is a real case that I saw, and we see lots of these cases. I'm sure you do also. This is a 37-year-old woman referred for newly worsening hypertension, otherwise healthy. She had no cardiac risk factors or renal risk factors. She's on an ACE inhibitor and a bit of potassium, interestingly. Her blood pressure repeatedly at home and in office. She does this at home because of insurance purposes, were quite high, similar in both arms, and even in the legs we did that. They were very similar. Her potassium that her family doctor sent ranged from 2.9 to 3.6. She had no diarrheal illness. She wasn't on any diuretics. She wasn't the typical anorexia, bulimia type patient, at least on history, and her GFR was normal. So just two questions in terms of food for thought. Any concerns with respect to this patient and differential diagnosis? And what would be your next steps for investigation and management? So, we get taught in medical school that secondary hypertension is not very, very common. Depending on who you speak to and the studies, probably less than 5%. But I'm going to convince you here it's actually much more common than that, especially when you go to secondary care centers and tertiary care centers. And if you look at the table on the left, depending on the center, it can be up to 12%. And the problem with defining how common it is, it depends on the cutoff for hypertension and the cutoff for hypokalemia. And the reason I mentioned hypokalemia exists in only about 40% of these patients, 40 to 50%. So hypokalemia is not a cardinal feature that's essential to make the diagnosis of primary aldosteronism. When you make the diagnosis of primary aldo, and I'll refer to it as primary aldo now, the most common cause is bilateral adrenal hyperplasia, or also known as idiopathic hyperaldosteronism. And the second most common cause is APA, or aldosterone-producing adenoma, also known as Conn syndrome. And other ones are much less common, especially things like adrenal cortical carcinoma, which is a very unfortunate condition, and the rare genetic cause of glucocorticoid-remediable aldosteronism. Again, these are the rare causes. I'm not going to go into this because this is a discussion for another time, but just keep in mind that adrenal cancer patients are much sicker. They're often the women in their 30s or their 40s with a large mass, and they're sicker, they're quite progressive, and they're often either non-functioning or plurihormonal, both with cortisol and aldosterone. So why should we worry about this condition? It's just a little bit of aldosterone, a little bit of blood pressure. We have lots of medications to help us out. Well, this is the problem. Compared to age-matched controls with essential hypertension, patients with primary aldo have a much higher risk of cardiovascular disease, chronic kidney disease, and a death risk profile. Just like pheochromocytoma, same thing's been done with pheochromocytoma and paraganguloma. Age-matched controls with pheo and essential hypertension, the pheos do much worse. So we all know from the cardiac data, with heart failure data, especially HFrEF or reduced ejection fraction, that aldosterone is bad. That's why we use drugs such as mineralocorticoid receptor antagonists to decrease outcomes. We just don't have this data in randomized controlled trials with primary aldo, but we can probably extrapolate until we get some more data. The other thing with primary aldo is often easily treatable and curable, depending on whether it's surgical or even non-surgical. They often need less medications. Surgery can be curable. Blood pressure control is better. We can often revert back to eukalemia, and they need many less medications compared to previous. And at the end of the day, it does improve surrogate markers of cardiovascular and renal function. Does it improve clinical outcomes? That story has been yet to be told. So we will find out, but it makes clinical sense and biological plausibility. So when do we suspect primary aldo? I wouldn't say in every single patient with hypertension you should start ordering aldosterone levels, but there are a few key important recommendations. Of course, if someone has refractory hypertension or controlled hypertension on more than 4 drugs, think about primary aldo. Now, that font is purposeful. So you might think, was I sleeping when I did this? I probably wasn't. But the font is lower because the evidence based on screening patients with sleep apnea is much lower, depending on the study you look at. So we looked at this very carefully, actually, when we were doing the guidelines for Canada, and we don't have unequivocal evidence that sleep apnea patients should be screened for hyperaldo. Although if you look at the Endocrine Society guidelines, they do recommend it, but again, guidelines are guidelines. And if their blood pressure is more than 150 over 100, you should probably have a lower threshold for screening for primary aldo. But again, it's just like you're looking for multiple clues. We never do medicine based on one clue, right? If we investigated everyone with hypertension with hyperaldo, we would be picking up a lot of false positives and causing unnecessary anxiety. So refractory and controlled hypertension on multiple drugs is a good clue to investigate. Number 2, if they have hypokalemia in association with their hypertension, probably a good reason also to screen for hyperaldo. But again, the caveat is not everyone with hyperaldo has hypokalemia. So if someone has normal kalemia, we cannot rule out hyperaldo if other pretest probability risk factors exist. But when do you really suspect it? If someone has unexplained spontaneous hypokalemia, which is less than 3.5 arbitrarily, or someone has very easily provoked hypokalemia, especially on low dose thiazide or thiazide-like diuretics, or even loop diuretics such as furosemide. Number 3, adrenal incidental. And lastly, someone who has hypertension and a family history of not essential hypertension, but a family history of hyperaldo. These are often patients who are younger and with hemorrhagic stroke, and that's more related to GRA, the condition that I mentioned earlier, the genetic condition, and all hypertensives with primary aldo and first-degree relatives. So these are really important clues to think about in terms of primary aldosteronism. So we think about the condition. We've done our history. We've done our physical examination, which is mainly looking for blood pressure and pulse and equality or inequality in both arms. What do we do next? We want to do a screening test. We want to test that is sensitive to rule out or rule in an important diagnosis, mainly to rule out, because at a mass population, you want to test that you can rule out so you can stop going further. And the best test is looking at an aldosterone, a renin, and a ratio. So people just think about the ARR, the ratio, but we need all the data to make the next steps. And I'm going to spend a little bit of time, not too much, to let you know that this has to be done properly, because aldosterone and renin are posture-dependent hormones. If they're done improperly, you're going to get inaccuracies in the results. So they should be relatively eukalemic. They should not have a restricted sodium intake. They should have normal renal function, although this might not be the case in all our cases, and we'll have to interpret based on the findings. And always think about interfering medications. Many of these medications need a 2 to 4 week washout, especially if you have false negatives or false positives. One caveat is I would not stop medications when you do the initial screening test. Only do a washout if the test in interpreting the test results of the medication don't make sense, or you suspect a false negative or a false positive. So go ahead and screen if your pretest probability is high, then decide if you need to do a washout after the fact. The most interfering medications are the mineralocorticoid receptor antagonists, and the main ones we use are spironolactone and eplerenone. And also think about beta blockers, clonidine, ACE inhibitors, diuretics, and ARBs, and also ACE inhibitors, ARBs. Although the ACE inhibitors and ARBs don't have a significant impact, but if you're finding a false negative, then you might want to go on to do a washout to avoid the false negative. Non-steroidal anti-inflammatories are very important in the diagnosis also in terms of interpreting these tests. So think about these drugs are used quite rampantly, at least in our part of the world, where they're not prescribed, so you can buy them over the counter, and they'll give false positives in many of these cases. And birth control pills, depending on the dosage of the birth control pills, etc. Keep in mind that renin is very important. This is a renin-dependent disease, which is the denominator in the AR. So if your renin is undetectable, your pretest probability is very high of this being primary aldo, especially if the aldo is relatively high. And what cutoff are we using for aldosterone? It depends on the study you look at, the assay you're looking at. But if you have a low renin, if you have someone with a renin that's detectable or lowish, but the aldo is less than 139 and there are no interfering medications that cause a low aldo, it makes primary aldo quite unlikely. So keep in mind, again, the points here are look at the renin, look at the aldo, and look at the ratio, all of them together to go to the next steps to make sure if you've got a positive screening test. And screening is usually not diagnostic. And the reason why I say usually, because there are times when it may be diagnostic, and I'll show that in just a bit. So this is something we published a few years ago because there was a need for primary care and generalists, general internal medicine, for primary care physicians, not for endocrinologists, unless they're not doing a lot of this. But what we found on a literature review at this point in time, if your ratio is less than 100, and the important thing to note here is the units. So this is renin mass or direct renin in nanogram per liter, not in renin activity, which is very difficult to do. We're not doing a lot of renin activity, at least in Canada, because of the cumbersome nature of it. If your ARR is less than 100, it makes it less likely, keeping in mind you're not on any interfering medications. If it's more than 144, the pretest probably is quite high, and then you should go on to do some confirmatory testing. And this is keeping in mind, again, no interfering medications or inaccuracies, and making sure the potassium is eukalemic and it's done properly. So if it's a negative screen and you think it's a false negative, then you want to do a washout with appropriate washout and use a clean study using either an alpha blocker such as doxazosin or the other ones, plus or minus long-acting non-dihydropyridine calcium channel blocker, plus or minus hydralazine. But we all know that hydralazine gives a lot of headaches and tachycardia, so that'll be the third line agent to be used in a clean study, and ensure a relatively good sodium intake. If it's a positive screen, they should be referred to a hypertension specialist who deals with a lot of these conditions. So this is a table that you can all get. I find this table very helpful. It's from the Endocrine Society about a lot of the factors, not only medications that interfere with testing. And the one that I really wanted to mention is potassium wasting diuretics, spironolactone, and drugs like amiloride and eplerenone. But as you can see, it'll take me quite a long time to go through all the different effects here. But keep in mind that there are a lot of drugs that interfere with aldo and renin levels, and a lot of it makes physiological sense. For example, ACE inhibitors. If you have decreased conversion of angiotensin to aldosterone stimulation because of ACE inhibition, you're going to get lower aldosterone levels, and as a result, you'll also get a reflex negative feedback of a high renin level. So a lot of it makes physiological sense. But this is a nice table that I sent to my residents to keep in their smartphone to refer to. Age also results in lower renin levels and lower aldosterone levels. So keep that in mind. That can give you a false positive. The other couple that I wanted to mention is pregnancy can give you false negatives. And premenopausal state, if you use renin activity, can give you a false positive. So keep these caveats in mind. Again, if you wanted a really pure study and you're wondering about inaccuracies of interpretation of your results of the ARR, these are the therapies that I've already talked about. They can really have a clean assay without any interference with the absolute aldosterone renin ratio. So to summarize, alpha-1 blockers, we use doxazosin most often because of its half-life. Diltiazem, we tend not to use a lot of verapamil because it's very constipating, and hydralazine if needed as a third line because of its concerns of reflex tachycardia and headaches and edema and so on. How do you confirm the diagnosis? There's a lot of tests, but these are the ones that have been used most commonly. Outpatient, you can do a three-day oral salt load. What you're basically looking at is aldosterone suppression. And you want to make sure they're adequately salt loaded and they're adequately caliuretic, so you get a good interpretation of the study. Pretty easy to do. I have a protocol that I send to my patients, and I'd be happy to share this with Dr. Mala to share the wealth with the rest of you here on the call today. Then we can bring them in with IV saline infusion, 2 liters over 4 hours. And there is debate now, probably more data coming that the supine is not as accurate as the seated. The seated is more accurate, but I'm giving you data for the supine because that's been historically what's been done. Again, the same thing, you're trying to show suppression of aldosterone to rule the diagnosis out once you have a positive screening test. So if your aldo is more than 280 after the NIT test, you can probably rule it in. If it's 140, you can probably rule it out. Anywhere in between is probably gray, although there's more data coming depending on the assay you look at and study you look at. 190 is probably the best cutoff. Number 3, a very strongly positive screen of the aldosterone-renin ratio is also diagnostic if you can include the caveats of the interferences. So if someone has spontaneous hypokalemia, that is very strong, along with undetectable renin, and aldo, which is unequivocally high, above 550 picomole per liter. You probably don't need to go on to the above to confirmatory testing. I'm sure some of you will ask me about the catheter suppression and fludrocortisone suppression test. Very difficult to do the fludrocortisone suppression test. It sort of scares me to give so much fludrocortisone and risk the hypokalemia and arrhythmia. So we tend not to do that. I think Australia is the only place that does the fludrocortisone suppression test. And captopril suppression often not done because we can often get away with these other tests here. What about imaging? The cardinal rule is until you have a biochemical and a clinical diagnosis, please don't do imaging because you're going to find, I don't even call them incidentalomas. We're calling them crapomas. Useless information that is not going to cause any clinical impact. And if you do CT scans and MRIs before, you're going to find a lot of incidentalomas, just like pituitary lesions on MRI without any thoughtfulness. And if you flip, it's basically a flip of the coin. The older you get and you have someone with primary aldo, half of them or a third of them will be non-functioning. So in older people where the diagnosis is still there for primary aldo, you probably need to go on to some lateralization studies, and that's the adrenal vein sampling. However, all that being said, in someone who's young, where adenomas are more likely functional. So someone who's young, who has unequivocally proven clinical and biochemical primary aldo, and they have an unequivocal lesion that's more than a centimeter, you can probably avoid adrenal vein sampling in that young patient because their likelihood of having that lesion being functional is more likely to be more likely compared to someone who's older. So what about adrenal vein sampling? Again, it depends on the center. The protocols vary, the interpretation varies. So you can do a stimulated protocol, or you can do an unstimulated protocol. We do both. So what we do at our center is we do a bolus with also a baseline study of aldosterone and renin, looking at both adrenal veins and the periphery, which we use as the IVC. One study did show that when you do stimulate them with ACT, it reduces the number of unsuccessful cannulations of both adrenal veins. So the interventional radiologists, again, they have to be experienced interventional radiologists to make sure this test is done properly, because it is quite difficult, especially to cannulate the right adrenal vein. So how do you interpret? Again, the interpretation depends on the center and the study that you look at. But this is the process. The first thing is you have to make sure you've cannulated the adrenal veins. And this is what we call the selectivity index. And you're looking at the cortisol from the adrenal vein to the peripheral vein. And the numbers that we're using are more the bold ones. So if it's more than 2 at baseline, unstimulated, it probably has been cannulated well. But with ACT stimulation, we're looking at a number usually more than 5. The second thing we need to do is doing a cortisol corrected ratio. So the aldosterone over cortisol for both adrenal veins and IVC respectively at the same time points. Once that's done, we can do a lateralization index, but we can only proceed to the LI only after you've made sure that you've got a positive SI. Because if you're going to do an LI on an SI when you don't cannulate the veins, it's meaningless. It doesn't mean anything. So you have to do this in this order, 1, 2, and 3. So the lateralization index is looking at the ratio, the cortisol corrected ratio of the higher number, which is the dominant, over the non-dominant side. So right over left, or left versus right, depending on what's dominant and non-dominant. And if it's more than 2 without stimulation, you've probably lateralized to that side. And with stimulation, if it's more than 4, you've likely lateralized to that side. If you don't get these lateralizing numbers, you're probably dealing with idiopathic or bilateral adrenal hyperplasia. So this is critical for most patients who you're going to send for surgery, except for that young person, like I said, who already has unequivocally proven hyperaldo with an unequivocal lesion on some kind of imaging, in particular CT. Another test that we use in conjunction, especially if it doesn't meet SI, the selectivity index, but it's still not 100%, is something called the contralateral ratio. What you're looking for here is basically the aldosterone, the cortisol corrected ratio is less in the contralateral adrenal vein compared to the periphery, which is again more in keeping that there's lateralization to the dominant side. So this is another clue in the workup to see if this is a surgical condition. So the reason I put this up is we're talking mainly about primary aldosteronism, which is the center, but another talk for another session is on the right. You have someone with a non-aldosterone mediated mineralocorticoid hypertension. This is where you have Cushings and exogenous mineralocorticoid and other rare conditions. And on the left, we have secondary hyperaldosteronism, which is something we often don't see. This is what nephrologists see, renal vascular hypertension or reninomas, which endocrinologists will see, and cardiologists at a young age with their patients will see coarctation of aorta. So we're looking at the middle, where your renin is suppressed or very low and aldosterone is high. And we're using the renin mass rather than the renin activity because of the commonness of the renin activity, which was traditionally used. So how do you manage these patients? We usually use the usual hypertension management, sodium restriction, lifestyle measures, cutting back on the alcohol intake. But the bottom line is you really want to treat the etiology and looking to decide if the primary aldo is either surgical or medical management. And if it's medical management, especially if it's bilateral adrenal hyperplasia, where medical management really plays into favor, spironolactone is the first therapy to go to. And often you need low doses. So if you're requiring more than 100 milligram a day, start thinking that there may be either a combination, either you're dealing with something else, or this is a combination of hyperaldo and background essential hypertension, which we all know is very, very common. Some people may not tolerate spironolactone, then you might need to go on to more of a selective mineralocorticoid antagonist, such as eplerenone, which is not as effective, but that does have less side effects, in particular with gynecomastia. And sometimes you may also need to use a Milleride. Beta blockers are not very effective because beta blockers affect renin, and these are all low renin type hypertensive patients. And of course, you may need to use some potassium, especially when you don't have spironolactone on board. But once you got spironolactone on board, we can probably wean off the potassium. And as with a lot of the endocrine tumors in the abdomen, laparoscopic surgery is often the best way to go in an experienced endocrine laparoscopic surgeon. So initially, almost all of them have improvement in their blood pressure and potassium if it is purely hyperaldo without any coexistent essential hypertension. But in the long term, only 50% get hypertension control because as time goes on, many of us do get essential hypertension. And this is quite cost effective at the end of the day because you minimize medication burden, hypokalemia burden, and hopefully improve cardiovascular and renal morbidity and mortality. This was a small study that did show that in those patients who had even adenomas, if they don't want to get surgery or they're not candidates, very small study, showed that there is no malignant transformation and they actually do well with medical therapy, such as spironolactone or a Milleride. This is a nice summary slide. Again, going back, you need a history and a physical, if your pretest probably is there. do the ARR. If the aldosterone renin ratio is very, very low, understanding the caveats of interpretation of other medications, you can probably rule out the diagnosis. But if it's high and the potassium is low, the renin is really, really low, and the aldo is high, you probably don't need to go on to confirmatory testing. So that's the circle on the top. So someone you've made the positive screen, but they're hypokalemic, undetectable renin, very high aldo, they probably don't need to go on to the other confirmatory salt loading tests, because that very high ratio in its sense, in its own, is diagnostic. But if it's not, doesn't meet all those criteria, then you need to go on to do that confirmatory testing. If the patient does not want to go to surgery or is not a candidate, just treat them with a mineralocorticoid receptor antagonist. But if they're young, or even if they're otherwise older with a good surgical candidacy, then you probably want to either go on to adrenal main sampling, especially if they're older. But if they're younger, as I mentioned, you can probably go on to, if they have an unequivocal imaging on CT, go on to a surgical referral. So what about normalization of blood pressure after surgery? Well, it depends. And this depends because many of these patients also have essential hypertension. What are the risk factors for getting good control after surgery for hyperaldosteronism, for aldosterone-producing adenoma? If you have a low incidence of essential hypertension in the family, you're likely to do well in the long term without any additional hypertensive therapy. If you're on not as many pill burden therapies preoperatively, you're more likely to have pure primary aldo and a longer term control. And younger age, shorter duration of therapy, a higher aldosterone and a higher urine aldosterone, you're more likely to have pure hyperaldo, and more likely you're going to be cured from the surgery, requiring less post-operative blood pressure therapy. Now, I'm just going to spend like a few seconds on this. This was done by Dr. Vadia, who works in the States. And again, there's no randomized controlled trials, but in some patients who have difficult to control even bilateral disease. So this is someone who doesn't have Conn syndrome or an adenoma, but has idiopathic or adrenal hyperplasia bilaterally. If they have difficulty to control disease, significant cardiovascular kidney disease, they're young and they're on a lot of medication, you may consider removing the largest adrenal. Again, this is on a case-by-case basis, talking to the patient and making sure that you may not get 100% results, but you may get less burdensome of therapies and better potassium correction. But again, this is a case-by-case discussion, and there are no randomized controlled trials. It just makes biological sense. Almost done, guys. So post-operatively, make sure we do check their aldosterone and renin to see if they have a remission. Stop all their medications, especially their potassium, because in fact, they can go into a hypoaldosteronism state. So stop all the medications, monitor them carefully. Even if they have essential hypertension, you're going to follow them along for a bit. Intermittently, they actually may need some fluids because they may become hypotensive, and give them a liberal sodium diet, and carefully monitor the potassium over the next little while to treat potential post-operative hypoaldosteronism, which is often transient, but in about 5% of cases, it can be permanent, especially if they've had pre-existing CKD, chronic kidney disease, or urine albumin elevation. And a small subset of patients, at least transiently, if not long-term, may need liberal sodium intake and transient fludrocortisone until the other adrenal gland recovers. So what's new? Not a lot. We've discovered some mutations, but none of this has actually helped us change management, and more will come with this, especially in more than 50% of Conn syndrome patients. But they haven't provided any new diagnostic tests for the way we manage them. One thing that is new is we're probably not picking up as many of these patients as we are. So we should be screening more of our patients with quote unquote essential hypertension, especially if we suspect primary aldo with other risk factors that I mentioned earlier, especially refractory or controlled blood pressure on more than or equal to 4 agents. So I don't know, Dr. Vaishla, I don't know how much time I have, but I have some questions. And going back to the case, do we have time for a polling?
Polling may be difficult because they are all in another room. The delegates.
No worries, that's okay.
Different room.
You can answer the question for the audience.
Sure. Okay. So the first question is, which drugs don't interfere with primary aldo testing? Or even if people can put it in the chat and I can look at the chat, because there's no right or wrong answer, right? It's just more interactive and fun if we do it this way. Now, I know there's a lot of smart people on this call today, so for time. Dr. Vaishla, how much time do I have? I just want to be cognizant of the next speaker.
I think we are already ahead of time. So you can just answer the question so that we can.
So the first, okay. So basically the answer to the first question is alpha blockers and hydralazine don't interfere. And so all of the patients with primary aldo have the following if no interfering conditions, except. So they all have hypertension, they all have high aldo, they all have low renin. So they don't, so the right answer is hypokalemia. So the teaching point here is if you don't have hypokalemia, you cannot rule out primary aldo. And the last question is, who should go for surgery for proven primary aldo? And the correct answer is if someone has an unequivocal CT localizing to the right gland on AVS, they should go for surgery. And someone who's older, who has an imaging study that's positive, it could be just an incidentalloma. And someone who has idiopathic or bilateral adrenal that's medical management. And lastly, someone who's 75 with a lot of comorbidities and it's too risky to stop medication, just keep them on spironolactone. So I'm going to skip this because we have a lot of unanswered questions on who should we be screening and do we have good outcomes in terms of clinical outcomes with medical therapy? And hopefully we'll get a lot of these answers in the future and about cost effectiveness also. So I'm going to end there with the case and I'd be happy to take some questions. Thank you very much.
Thank you, Dr. Ali. I think that was an extensive coverage of a very difficult topic in a short span of time. And I think Dr. Sriram has set questions in the chat box. If you can just ask them yourself, that would be easy.
If you have time, we have time, no, to discuss.
Yes, Dr. Sriram, you can ask the questions.
With the difficulties in getting very good assay, especially of PRA in our setup, the renin activity. So there is a suggestion, I think the JCM paper also mentions about the direct renin assay. So your experience with that, and because the PRA is more fallacious and because it is in the denominator, if it is going low and you are over-diagnosing sometimes is what I sometimes feel.
Yeah, so we are using 95% of the time we're using direct renin or the renin mass, and again we have a pretty strong lab that we're doing quality control, so we have not had any significant issues. But keep in mind the most significant issues we've had is with all these drugs being on board, right? Making sure we're interpreting the drugs with the testing with aldosterone and the renin and the ratio. But we haven't run into too many troubles with our renin assay. Again, we have more experience with the renin activity, which has been historically used in the past. But I think all of us will have to somehow get used to the renin with better assays, and that's the nature of the beast, right? So that's what we have right now.
Thank you. And what is that confirmatory test you do in your setup?
That's a good question. So if possible, our patients will have a very positive ARR. That's great. If they have a very high aldo, undetectable renin, hypokalemia, then it makes our job very easy. But many of our patients don't have that because they're taking lots of medications in their primary care, treats them as essential hypertension. So the one we use is we ask the patient, you want to come into the unit? Now, COVID time, we didn't bring them in, right? So there was a year where we did everything outpatient because it was just, we wanted to minimize hospital exposure with the coronavirus. But now we ask two questions. What does the patient want to do, number two? And does the resident want to supervise and get some experience in doing the inpatient saline infusion? So we decide based on first of all, what's most important is the patient, and number two, is there any teaching value for the residents? So we use those use factors. Number three, if we have an equivocal result from the outpatient load, then we'll consider doing a saline infusion and bring them in, or vice versa.
It does.
So Dr. Sriram, Dr. Vaishali, any questions? There are no questions in the chat box. I'm not finding any questions from the delegates.
Sorry, Dr. Mala, there is one question here. What we put in
that was Sriram's question only.
The need for AVS in all patients when we have potent drugs.
Yeah, so the need, that's a really good question. So like I said, if you're going to go for surgery in someone who's older, even if there's a positive lesion, that still might be a third to half of the time, might be an incidentalloma. So we've had cases sent by outpatient physicians who don't do a lot of primary aldo or endocrine hypertension. They see a lesion, they've proven the diagnosis, they get the left adrenal removed because that's what the lesion on the CT. Post-operatively, their blood pressure and their potassium is the same. They're hypokalemic because the lesion actually was so small, it was on the other side, and no AVS was done. So the simple answer is someone who's older, even if they have a lesion, you should probably do AVS. But in someone who's younger, and who's young, probably less than 35, less than 40, if they have proven primary aldo, unequivocal lesion, then that younger person, you can probably get away with not doing AVS and the reason why is the pretest probability of someone who's younger who has a lesion is more likely functional rather than non-functional. But as you get older, these lesions tend to become more non-functional based on epidemiology and probabilities. It's all about probabilities, right? Any of you who gamble, in medicine, we're always hypothesis generating and basing things on probabilities. And there was one last question about
Finerenone.
So no, we don't have any data with finerenone. The data we have with finerenone is in chronic kidney disease and diabetes with cardiovascular outcome trials and renal outcome trials. But I don't know any of any studies looking at it in hyperaldo. It makes sense. Its difference is it's a non-steroidal mineralocorticoid receptor antagonist, unlike spironolactone and eplerenone, which are steroidal. So no data as of yet. I'm sure there will be in the future, but nothing yet.
A small corollary to that first question which I asked is because there used to be a concept called low renin hypertension among the essential hypertension people, no? So we were wondering with a lot of data coming up on primary aldo being subclinical and missed in many patients. Yeah. Why not the eplerenone be part of the hypertension algorithm itself? Why we do so much of all this detailed testing? You put like diuretic is added in the second or third in the thing. You put eplerenone also in a normocalemic or lowish potassium or something like that. Is there any thoughts on that?
Yeah, so that's in fact when we revised the last guidelines for Hypertension Canada in 2020. I'm a big MRA fan or mineralocorticoid receptor antagonist, and we've actually really brought up in refractory essential refractory hypertension. We have to move up our MRAs, right? Because beta blockers are useless for most, unless there's another compelling indication. So ACE inhibitors are great. Thiazide-like diuretics are great. Dihydropyridine calcium channel break. In fact, we should be introducing for refractory or resistant hypertension, spironolactone much higher up. In fact, there was a study called the Pathway Study, which you may be aware of, looked at spironolactone versus other third line or fourth line agents, including alpha blockers and other agents. And spironolactone came out beautifully, had the best reduction in blood pressure in terms of both systolic and diastolic. So absolutely, Dr. Sriram, that we should be really using for these refractory essential hypertensives, mineralocorticoid receptor antagonists much higher than we did in the past. They're easy, they're cheap, just got to monitor their potassium and a little bit of gynecomastia. If they do get gynecomastia, we can switch them over to eplerenone.
Thank you, sir.
I think that's all in the chat box. Thank you so much, Dr. Ali. It was a wonderful interaction, a very lucid presentation, and a very good learning for all our students and us. Thank you so much.
Thank you very much for having me. All the best.
Thank you. Thank you for a very good session, Dr. Ali. Thank you for joining us. And thank you, Dr. Vaishali and Dr. Sriram. Dr. Sriram, please stay back. We have the last topic for today, which is osteoporosis in premenopausal women. We've heard a lot about postmenopausal women, so we are going to hear about osteoporosis in premenopausal women by Dr. Vaishali. Dr. Vaishali, over to you.
Thank you, ma'am, for that introduction and inviting me here today. Thank you, Microlabs, and thank you, Dr. Das, sir, also for having me here today. So I'll be talking on this topic. It's a very vast topic. I'll try to cover it as early as possible within 20 minutes. This epidemiology of premenopausal osteoporosis is not exactly known because there is a variability in the prevalence right from 0.5 to 50% prevalence reported in various studies depending on the population studied, the definition of osteoporosis used, and the referral centers which are doing these studies. So if you have to talk about our own Indian data, we have data from Pune with the population above 40 years of age. These women, the prevalence of osteoporosis was to the tune of 3.5% based on the DEXA T-score guidelines. And you have a huge registry by orthopedicians in India, and that mentions the prevalence in the tune of 18%, but that was mainly with the hip calcaneal BMD. So you really cannot standardize the prevalence data as of now unless we have a uniformity in these analysis. But disease-specific prevalence does exist, and you can see the prevalence in SLE is around 17%, in rheumatoid arthritis around 7%, in Cushing's disease around 44%, 35% in HIV, 45% in cystic fibrosis. This has been in various meta-analysis from all the studies worldwide. Why is it important to know? Because A premenopausal woman with a prior fracture has nearly 35 to 75% higher risk of having a fracture in the postmenopausal years than a premenopausal woman without a fracture. So it is important to identify and investigate and treat a patient with a premenopausal fracture. Early diagnosis management is very beneficial and it is curative in most of the cases. So treating the cause and the etiology of this is mainly curative. Why is it important to understand premenopausal osteoporosis? Because there are various factors which affect the peak bone mass and the fracture risk in a woman. And it begins with right from bone accrual in childhood and adolescence to bone microarchitecture, which has been genetically determined, along with lifestyle factors, dietary factors, and disease factors. Apart from this, you have a lot of mechanics of the body being involved in the form of lean body mass, muscle power, physical activity, being a primary determinant of positive bone mass accrual. Apart from this, sexual development and function of a person also determines how much bone mass accrual is going to occur. Simultaneously, the other anthropometric parameters like BMI and height also determine the same. There is a negative association of history of amenorrhea and menstrual disturbances and androgen excess and the age of menarche. So all these factors are known to have impact on the bone of any woman. And you can see that this is for our students especially. This is a female athlete triad. This is a triad where there is menstrual dysfunction, low caloric intake, and a low bone density. So all three coming together in an athletic woman is this is classically associated with the high prevalence of osteoporosis in this population. Then coming to the diagnostic criteria. So you see that the diagnosis, of course, is based on the DEXA, but the International Society of Clinical Densitometry defines osteoporosis in premenopausal women as BMD Z scores below the -2 range of SD to define the low bone mass. This is taken as the cutoff for defining osteoporosis in this category, while IOF mentions that this same Z scores are used, however, only before the age of 20 years of age. Thereafter, the adult definition for postmenopausal osteoporosis has to be used in those older than 20 years, especially if there is no delayed puberty associated. So the definitions differ, but nevertheless, it is important to identify that the Z match, the age match scores are more important than the population match scores of T-scores. So you need to identify this in light of various other common clinical risk factors, the diseases involved, and drug-related factors which are involved in secondary osteoporosis. All this needs to be taken into account. It's not a single T-score diagnosis or a Z-score diagnosis that needs to be done. So low BMD alone does not necessarily represent osteoporosis in a premenopausal woman unless you have some evidence of microarchitectural dissociation or there is presence of multiple fragility fractures in the vertebra or elsewhere. So you need to have a combination of all this to label a premenopausal woman as a premenopausal osteoporosis patient. There can be a confirmation with a high resolution PQCT, which is now easily available in the metros. So what one needs to understand that when you're interpreting the bone density, there is a need to know the normative databases of that particular population. Unfortunately, we don't have a lot. There are a lot of normative databases being developed for premenopausal women, and they may not, actually the bone mass which has been detected may not reflect a final peak bone mass because the bone mass tends to increase even up to the age of 30 years. So even especially if you are using it for an underage or below 25 years of age, it's likely to be really not the actual bone mass of that particular woman. Childhood factors like nutrition and medications are usually tend to, they may no longer exist in adulthood. So they may not have that much of impact that they would have in the childhood. And we need to understand that in the setting of normal pregnancy and lactation, there is a recovery of this bone mass within 6 to 12 months. So if you're doing a bone density during this period, it may not be the actual bone density because that may recover eventually. Specific therapies of the diseases actually with anti-resorptive and anabolic agents tends to improve the bone density, but there is no evidence that they will improve the fracture risk. So you may get a bone density improvement eventually with therapy, but whether that translates into reduced fracture risk is not really well known. So coming to what causes or etiology of fractures in this particular population. So lifestyle and dietary habits, mainly excessive alcohol consumption, heavy smoking have a very high hazard ratio for occurrence of fractures. Then consumption of vegetarian food and veganism is known to have a poor bone mass, and meta-analysis have proven that they have a higher fracture risk as compared to the non-vegetarianism. And hypovitaminosis D in various forms, whether they are associated with intestinal malabsorption, osteomalacia, or malnutrition, all are known to be associated with high chances of osteoporosis. What one needs to understand is that in this age, the commonest cause of osteoporosis is secondary. So it is usually due to underlying disease, nearly in 50 to 90% of cases. So there are various causes. I'm not going to go through all this, but what we need to understand is that any systemic disease can come with osteoporosis, including inflammatory disease, infective disease, endocrine disorders, then genetic diseases like hypophosphatasia, osteoporosis, pseudoglioma syndrome, and anorexia nervosa. So all these have been reported. There has been a huge list which has been categorized as to why they should be having osteoporosis. But what we can understand from this red colored mouse is these are the commonest condition we come across with osteoporosis. So any childhood disease that is affecting the puberty or skeletal development, then presence of premenopausal amenorrhea, hyperthyroidism, alcoholism, primary hyperpara, vitamin D deficiency related disorders, rheumatoid disorders, and many medications of which steroids, the glucocorticoids forms the key products which are known to cause osteoporosis, but nevertheless, cancer chemotherapy and hormonal contraceptive, especially the POPs, are known to cause osteoporosis in a significant population. So then coming to specific types of osteoporosis in this population. So this is what we call as pregnancy and lactation associated osteoporosis. The commonest cause of this being a derangement in calcium metabolism occurring in pregnancy, PTHRP released from breast and placenta, and there is an osteoblastic dysfunction with a low bone turnover state. This is probably also a mild form of OA because there have been some genetic associations with the same. The best part of it is that the prognosis is good. It is reversible. It may or may not have long-term negative effects on the bone, but definitely needs a treatment and attention when it occurs. Cancer-related osteoporosis is also an important diagnosis. Why it is important? Because cancer itself or cancer treatment, both can be the root cause of it. And especially in hematological malignancy, this can be seen that both the cancer and the treatment, so transplants and post-transplantation therapy is known to cause osteoporosis. Similar kind of phenomena is seen with breast cancer, where they have found that adjuvant chemotherapy is known to cause osteoporosis. And in fact, they have proven that zoledronic acid given every 3 months for 2 years is known to prevent this bone loss and improve the disease-free survival in these patients. Very interestingly, tamoxifen, which is used in premenopausal breast cancer patients, is known to act as an anti-estrogen in premenopausal women. So there is a high fracture risk in premenopausal women who are on tamoxifen, in spite of we being using it as a drug for postmenopausal osteoporosis. Then glucocorticoid-induced osteoporosis, again, is a complex phenomenon. It's seen with autoimmune and inflammatory disorders and rheumatologic disorders where long-term steroids are given. Glucocorticoids we know are very deteriorating to the bone health, but we need to understand that they also help in controlling the underlying disease. So in situations, they may also reduce the disease-related bone loss. So it's you can see a balancing activity of glucocorticoids, and one needs to understand this phenomenon. Then coming to idiopathic osteoporosis. So if you see the idiopathic osteoporosis, now when you have ruled out all these diagnoses, what remains is a diagnosis of a low trauma fracture with the presence of low BMD, and you have excluded all the secondary causes, and you found that the volumetric BMD and the microstructure is deteriorating, and that is where you label this as idiopathic osteoporosis. The exact cause is not known. Probably it's genetic, probably it's related to osteoblastic dysfunction. Novel genes are identified, and if we understand that LRP5 variants are also known to be present in idiopathic male osteoporosis, the similar kind of gene has been identified in idiopathic female osteoporosis. Now, this is an entity which is a very puzzling phenomenon. You have isolated low BMD without fragility fractures in a premenopausal woman. What do? Do you really treat them? So here a single low BMD measurement may or may not be signifying active bone disease. So it is necessary to follow up these every 1 to 2 years and see what happens. If the BMD is declining, you may need treatment if the Z score falls below 4. But if it is declining and or maintaining stability, or it is remaining on the higher side or is recovering, you may not treat it, but definitely needs lifestyle correction, calcium and vitamin D supplementation, and exercise guidance for prevention of postmenopausal osteoporosis in these women. So this is, in short, a tabular formulation as to what we need to see when we have a premenopausal woman coming with osteoporosis. So you need to see the medical history of adult and childhood fractures, illnesses, menstrual history, timing of pregnancy, lactation, dieting, exercise behavior, gastrointestinal symptoms, nephrolithiasis, family history of osteoporosis. You look out for deficiency signs and symptoms, Cushing's syndrome, thyroid hormone excess, connective tissue disorders, and inflammatory conditions. So evaluation for the lab is indicated for all premenopausal women who have low trauma fractures, irrespective of the BMD. So premenopausal women with BMD Z score below 2 need to be evaluated with a lab. So definitely you need to do the routine laboratory to rule out primary hyperparathyroidism and hyperthyroidism and vitamin D deficiency. And in additional tests may be needed to identify the secondary causes, which I just mentioned. So you may require a battery of tests in accordance to the clinical presentation, depending on what type of illness you're suspecting. So coming to the management, you have non-pharmacological approaches. So there is a need for osteoporosis preventive behavior, which includes many lifestyle changes, along with physical exercise activity, which involves aerobic resistance training and milk consumption around 500 ml daily. There's a need to quit smoking and alcohol, and calcium intake to the tune of 1000 milligram per day, vitamin D 600 IU per day. Now, it is challenging to treat because it is difficult to predict how the future fracture risk is going to be. But definitely it is easier to treat the underlying disease. So estrogen replacement, especially with a combined OC, for those with estrogen deficiency is known to improve the outcome. But in patients who are estrogen depleted and sufficient, it is known to worsen the outcome. So be sure that estrogen works only for estrogen deficiency. Discontinuation of medication, especially where medroxyprogesterone acetate has been used for contraception. Then gluten-free diet for celiac disease, nutritional rehabilitation and weight gain for anorexia nervosa, and parathyroidectomy for primary hyperparathyroidism is needed. So anti-resorptive therapies in various forms are indicated in glucocorticoid-induced osteoporosis, cancer-related osteoporosis, and pregnancy-associated osteoporosis are benefited with bisphosphonates. What about idiopathic osteoporosis? The role of teriparatide and bisphosphonates continue to be established. However, none of the studies are powered to demonstrate fracture reduction. So I will not go in the depth of these studies, but the drugs are mainly preferred in specific. Bisphosphonates are category C in pregnancy, so they should be avoided or used with caution. And teriparatide is definitely not indicated during pregnancy. And if you're using in women less than 25 years of age, you need to document fused epiphysis before using the drug. And denosumab is not yet indicated. It's contraindicated in pregnancy and lactation. Teratogenic effects need to be thought of during usage of these drugs, and especially bisphosphonates and denosumab and teriparatide have certain teratogenic effects. And we need to remember that once the treatment should not be initiated in women who has been planning pregnancy or either in the next 12 months of conception or lactation, so that the benefits, the teratogenic effects would not occur. So this is an algorithm to see whether the patient is having osteoporosis. You correct the vitamin D status, then you look out for the secondary causes. If the secondary causes are absent, you label as idiopathic, then you treat with bisphosphonates, teriparatide. Denosumab can be offered in patients who are not planning pregnancy. So meta-analysis have shown, these are the studies, and I mentioned that various diseases have been reported to have various prevalence of osteoporosis. Similarly, tamoxifen, aromatase inhibitor, and GnRH or analogs are known to cause this. And if you see the benefits of treatment, the controlled trials of anabolic and anti-resorptive agents, ibandronate, calcium, vitamin D, zoledronic acid, teriparatide have been the agents of choice in various conditions. What about our experience? I'll just end with our experience of 6 cases of premenopausal osteoporosis. One was a 27-year-old mother who delivered 2 children, and she came for the 3rd delivery. She delivered, and the next day she fractured her neck, femur. So she attributed that to the lithotomy position. However, she was found to have a PHPT, and the adenoma was diagnosed and operated. Then a 24-year-old lady, mother of 1 child, came with both lower limb weakness. She was found to have hypokalemic periodic paralysis with vertebral fractures, and she was diagnosed to have renal tubular acidosis and SLE, and she needed treatment for both. Then 3rd patient came from an orthopedician with non-healing fracture shaft femur, and she was suspected to have renal tubular acidosis with a positive acid load test, treated for renal tubular dysfunction, and that fracture healed with that. 4th was an IT professional with severe pain and weakness in all 4 limbs, and she was found to have just severe osteomalacia, hypovitaminosis D, secondary HPT, severe osteoporosis, no fractures, treated with calcium, vitamin D, and oral alendronate. Then was a patient who came with premature ovarian failure at age of 21 years, not on HRT, was not taking any treatment. She came with a hip fracture to the ortho, found to have severe osteoporosis, started on teriparatide, followed by oral bisphosphonates. And then the last patient was CA breast survivor on tamoxifen who developed back pain, was investigated for metastasis, found to have a osteoporotic vertebral fracture, started on teriparatide, followed by oral bisphosphonate. So this is just a difference between the pre and post-menopausal osteoporosis. Diagnosis is based mainly on Z-score and T-score, not only on the T-score. Pathophysiology is mainly in the form of poor bone accrual rather than the bone turnover. The causes are mainly secondary. The bone turnover is not necessarily elevated in these patients, and treatment of underlying pathology is very rewarding. So to summarize, Z-score and combined risk factors with history of fragility fracture is required to make a diagnosis, and treating of the underlying cause is very beneficial. Bisphosphonates have a good safety data in women at childbearing potential, but the safety of these patients drugs have been scantily studied, so you should avoid them in the peri-pregnancy and postpartum period. So that's all in this presentation. Thank you so much, and for the patient listening.